Good evening, everybody. I hope everybody's doing well. Hello, hello. We have some newcomers too. That's good. Everybody feeling good? All right, good. That wasn't that bad yesterday, right? We went through a lot of material, right? I know. All right, so look, I'm gonna send you guys my email. All right, don't let me open my email and find 150 emails. But send me questions so we could sort things out. A couple of you that have been in the older class, 140. Sophia, I get 170 emails at work. All right, so some of you already have sent me emails. They had my email from step one or step three. I don't know. So they're great questions. All right. All right. So 5 minutes. I got to do a quick review. You guys remember what's classic for the serum osmolality? Serum osmolality in SIADH. All right, Tyler says hypo. Nah, not increase, decrease. That's right, low. I said SIADH, not DI. Hyponatremia, so serum osmolality is decreased, right? All right. See, Carol just started, and you know this already. See, so you didn't have to come yesterday, right? There you go. All right. So very good. Okay, what is the BUN and the uric acid in SIADH? All right, low. You guys are all over this, right? So why is it low? It's dilutional, right? All right, dilutional. Very well. Very okay. What's the primary treatment of SIADH? Primary treatment. So yeah, so some of you say, so we start off with the simple stuff, right? Water restriction, all right, fluid restriction. So I didn't mention salt tablets. So most people don't like that, but nah, you're probably right, Natalia. So fluid restriction and then democlocycline, okay? There's some other stuff like you guys mentioned. All right, okay. How do I treat Decurvence thyroiditis? What's the treatment of Decurvence thyroiditis? All right, supportive. Very good. There you go. Supportive. NSAIDs, aspirin, all that stuff. All right. How about what is always elevated in Decurvence? Very good. The SED rate is always elevated. What does the radioactive iodine uptake scan show in Decurvence? Boy, you guys are fast. All right. Okay. What's the radioactive we worried about? We worry about this may be cancer. All right. Okay. What's the most common cancer in the thyroid? Papillary. Very good. Is that a good cancer or bad cancer? Good. So 90+% survival of 10 years. So that's why they don't want you to miss it, right? Because they want you to treat it. It's very treatable and curable, right? And then you treat it and cure it and it's good. That's why they don't want you to miss this cancer. All right. So a 32-year-old man comes for the evaluation of a neck mass. You find a 2.5 centimeter thyroid nodule on the left thyroid lobe. There's no lymphadenopathy. The vitals in the examination is otherwise normal and no evidence of thyrotoxicosis. Okay, now look at here, right? So cancer usually doesn't have any symptoms. I mean, symptoms of hyper or hypo, right? So look at here. They give you the examination, and I'll give you this, that the TSH is also normal. Okay, so they said, what would be the next appropriate step? Okay, everybody okay with that? All right, so the answer is fine needle aspiration. That's the answer. Okay, fine needle aspiration. So I know some of you guys said get the radioactive iodine uptake. I know what the uptake's going to show, right? No, a lot of people, where I did my training, people used to use the radioactive iodine uptake scan for this. But see, look, I know. That's right. TSH is normal, right? You know that the radioactive iodine uptake scan is going to show what? A non-functioning nodule there, a cold nodule. How do you know that? Because the thyroid function is normal. It's a non-functioning, it's a cold nodule. Okay? Everybody understand that? So the story is that if it's a hyper-functioning nodule, you don't need to worry. Right? It's hyperthyroidism. You're done. You don't have to worry. If it's a cold nodule, you're in trouble. You gotta presume it's cancer until proven otherwise. That's why we get a fine needle aspiration here. Okay? Everybody understand that? We don't get the radioactive iodine uptake scan because I know what it's going to show. All right, well, let's say they give it to you. All right, so if they give it to you, it's going to be a cold nodule. You got to do an FNA. If they give it to you and it's a hot nodule, you could probably wash it. Everybody understand that? But I know that it's a cold nodule because I checked the TSH and I did an exam, and this patient had no evidence of hyperthyroidism. Everybody okay with that? So what do we always do in a thyroid nodule that's non-functioning? An FNA. Okay? What do we get before? We do a good exam and we check a TSH. If the TSH is normal, the exam is normal, FNA. All right. Everybody okay with that? All right, so look at here now. They may try to stump you in one more issue. Everybody okay with that? So look at here. I use what to guide the fine needle aspiration? The ultrasound, right, or an echo machine. Good. All right. So a sonogram, right? So most people do procedures now with the sonogram. Everybody okay with that? Look, why did I use the ultrasound here? To guide the fine needle aspiration. I didn't use it to tell me it's cystic or not. Hold on. That's why I'm telling you this. You didn't do it to find a tumor. You have a nodule there. You did it, what Tyler says, to avoid vessels, not to get a complication, not to go blindly like I used to or the other physicians 10 years ago before the sonograms, and we used to poke in there and biopsy. Everybody understand that? So why am I using the ultrasound? To guide me so I don't have any complications. Even if this is cystic, it needs fine needle aspiration. So I'm not using the ultrasound to tell me yes or no, right? I'm using it to do the fine needle aspiration. The bottom line, these patients need fine needle aspiration. Okay? Everybody feel comfortable with that? Okay, wonderful. All right, very good. All right, wonderful. Okay, so what's this? What am I showing you? I'm showing you what you guys, some of you guys asked, right? And look at here. This guy's got a cold nodule, right? I don't have to do this. I don't have to do this. Okay, but if they give it to us and they say, look at this radioactive iodine uptake scan, what's the next step here? Right? You see this area here? It's no uptake here. It should have been like this, right? Okay? It's still FNA. FNA for here, right? I need to FNA this. Okay? If it's benign, then you don't have to worry about anything. You may want to watch this person, 6 months, a year later, just to make sure it hasn't grown. right? If it's cancer, you get the surgeon to take it out. Here in this country, you do total thyroidectomy. Okay? Everybody okay with that? All right, so they may ask you something about the evaluation of thyroid nodules. All right, so which thyroid nodules? So if my FNA shows cancer, right, I do a total thyroidectomy, right? If this shows cancer, if it's benign, I don't do anything. Okay? So you can see there's no uptake in that area there, that red area. Now, in this country, we do total thyroidectomy. Okay? Everybody okay with that? Okay, very good. So everybody feel comfortable, right? All right, so remember, if a guy has gotten radiotherapy to the head and neck area, right, that puts him at risk for thyroid cancer. If you have a thyroid nodule and you have lymphadenopathy, that is likely cancer, right? Everybody okay with that? No, in thyroid cancer, there's never palliative treatment because papillary anyway, because it's very curable, right? We're going to talk about this in a little bit. So you always try to do something about it. Okay? Everybody okay with that? Good. So this is a good question for you guys. What to do with a thyroid nodule, non-functioning thyroid nodule? All right? Okay. So we need to know a little bit about the different types of cancers. Okay? So number one, about 70% is papillary cancer. All right? This is good because you guys told me this is the one that is very benign, and you are correct. So over 90% of the patients live more than 10 years. So it's a relatively curable disease, especially if you catch it early. That's why they ask us a lot of questions about how to evaluate thyroid nodules. All right, so a little bit more. Papillary cancers usually happen in younger people. They metastasize slowly. Only at the very end do they metastasize to organs and bone and stuff like that. They usually have a very predictable movement, right? They go to the lymph nodes, right, close by, and then they go to more lymph nodes, and then more lymph nodes, and then, stage 4 and stuff like that. You may get something like, bone or organ mets. The bottom line is very predictable, right? So yes, they metastasize primarily to the regional lymph nodes. Very predictable. Okay? Follicular is the second most common. It is also has a good prognosis. So they say about 60-70% survival, 5-10 years. Right? This is good. Other cancers, we don't have that. All right? Older patients tend to have follicular. All right? Now, the bad thing about follicular is it may have hematogenous spread. So it's not like papillary where, kind of affects the regional lymph nodes and stays there for a while. It tends to be more aggressive. So if we find about, right, so Sandra says they metastasize to bone and liver. So that was a question, right? So if I have thyroid cancer, right, with bone and liver mets, right, what type of thyroid cancer is it likely? Okay, if I had to take an educated guess, I would say follicular. Okay? Remember, everybody, for our purpose, gets total thyroidectomy. Okay? Everybody. All these cancers, we'll make it easy. Everybody gets total thyroidectomy. Okay? All right, so look at here now. Yeah, so bone, liver, other organs. So I picked the liver because it's a common form of Mets. I mean, it's not So you could get it to any foreign organ, right? So the point here is that it doesn't stay in the regional lymph nodes, right? It goes to organs, relatively quicker than papillary. Okay? All right, so look at here. So then we have medullary. All right, so tell me a couple things here. This is not the typical thyroid cancer, right? What type of cells does it come from? The parafollicular, right? The C cells, or what's another name for them? C cells or calcitonin, right, cells, right? Everybody okay with that? Good. That's the way you think about it. So medullary cancer is about calcitonin. It's about parafollicular, about C cells, all that business. It's a rare cancer, right, compared to papillary and follicular. So it's much rarer, but this is also relatively curable. So they say about the cure rate here is about 60, sometimes 70%. So they're pretty good cancers here. The other interesting thing about medullary cancer is multiple endocrine neoplasias, right? So they occur with multiple endocrine neoplasias. So we'll talk about these syndromes later today and some more when we talk on Saturday. Okay, and then I like you, right, to think about this right here, okay? Right here, okay? So familial, all right? Familial solitary, all right? So what does that mean? What does that mean? Familial solitary. Right, so, but solitary, what's solitary? What am I getting at here? So you don't have to have multiple endocrine neoplasias, right, and stuff like that, right? You got no other neoplasias, right? Very good. So you could have in families, right, familial solitary thyroid cancer, medullary type, right? So this, the guy says, my brother had thyroid cancer, my father also did too. There you go. So watch that. There's a question about that. And then last is anaplastic. Oh, this is a rare cancer, and good that it's a rare cancer. It's probably, the rarest one because it's the worst one to have. It occurs in older patients. So anybody know the survival? The survival is less than 5% in 5 years. So remember, papillary is 90%, right? Follicular, I told you, maybe 60, 70. Medullary, same thing. But this has a severe, a bad, very, very bad prognosis. It's one of the worst cancers. The thing is, it doesn't metastasize to other organs, so it invades locally, right? Yeah, so maybe, a couple of years, right? Less than 5%, 5 years. Okay? Everybody okay with that? Yeah. All right. So look, for all our thyroid cancers, there's some small exceptions, but what we're going to know is primarily, for papillary especially, thyroidectomy, right, is the way to go. Thyroidectomy, and what did I say? What is it? What type? Total. There you go. Total thyroidectomy, all right? So some of you say, okay, does the patient get anything else? And the answer is yes. So sometimes we add radiotherapy ablation to that. So that's plus or minus, okay? So if you have lymph nodes, right, that are positive, you give XRT, right? If the patient has a big mass there, some people say give radiotherapy, right? So there are reasons to give radiotherapy beyond the surgical intervention, but this is considered a surgical disease. Okay? Everybody understand that? So they're not going to ask you guys, hey, when do we give XRT? That's a board's medicine question. But they may tell you this person got thyroidectomy, total thyroidectomy, and we gave him XRT. They usually give XRT when there's worry about expansion or they didn't get all the tissue or there's, spread to the regional lymph nodes or you got a big cancer. Okay? Everybody okay with that? That's easy, right? All right. So now there's two questions, follow-up questions that they could ask you guys. One is, what do I follow? What do I follow as a marker of the disease? I mean, if the disease came back. Now, I don't follow calcitonin, right? Unless unless it's medullary, right? So papillary and follicular most common. So I follow thyroglobulin, right? I knew you guys know that. Okay. So thyroglobulin, right? Everybody okay with that? So how do I follow thyroglobulin? When the patient comes for a follow-up, right? What do? I check my thyroglobulin levels, right? And what do I want them to be? 0. That's the right answer. Okay? Absent. All right? Everybody okay with that? All right. Wonderful. Absent. Zilch. Okay? What if I see the thyroglobulins levels come back high, right? Or they're increasing. Then you got recurrence of disease. Okay? All right. And then, so that's one concept you guys got to remember, right? All right. Or you got ectopic, Zainab said something very smart, right? You said about ectopic tissue. So look at here. So what the surgeons do, right? Because you could have ectopic tissue. Then you don't know if it's the cancer coming back or the ectopic tissue. What do you think they do? So after they do the surgery, right, they get a baseline, right? They get a baseline usually, thyroglobulin. And then if it's 0, right, they start from there. So if you see it 1 year later and the thyroglobulin comes up, you know that there's recurrence of disease. Right? Sometimes if they leave ectopic tissue inside or they don't get the whole cancer, the thyroglobulin level never comes back to normal. Right? And then they sometimes decide to radiate the area. Okay? Everybody okay with that? All right. When you do total thyroidectomy, right? Total thyroidectomy. What do you give back now to the patient lifelong, forever? What are they going to get back? T4. All right? T4. All right. Very good. All right. You guys got it. All right. So look at here now. There's a theory that if you have thyroid cancer, the thyroid cancer cells get activated by TSH. They can get activated. So if you left a little cancer in or the patient had a little bit of extension of the cancer and you didn't pick it up because we don't have sensitive enough tests, right? That can recur. And one of the ways it can recur is because it gets activated by TSH. So when I give back in thyroid cancer, I give back hormone replacement treatment. I give higher doses. Or I use T3 because it's more potent. And by being more potent, it suppresses TSH. All right, so look at here. I give higher doses of T4, or I may consider to give T3 because I want to suppress TSH. So I'm giving higher doses. I'm giving more than I should. Right, I'm using the negative feedback to suppress it. So I'm making this patient a little on the hyper side. Why am I doing that? Why am I doing the hyper side? Because I want to suppress the TSH. Because I'm worried. Right? I'm worried that this may activate the cancer cells. Right? So we usually use T4. So most people prefer to use T4 in this country for everyday disease. But I told you 2 scenarios where T3 is used. Myxedema coma and sometimes thyroid cancer. Okay? So in those cases, T3 may be preferable. Okay? In the rest of the cases, primarily in this country, we mostly use T4. Okay? Everybody okay with that? All right, so watch this. Let me give you a case. Make sure you understand this concept. A 34-year-old woman with history of papillary thyroid cancer. Okay? Removed 9 years ago. All right? She takes Synthroid 250 micrograms per day. Right? Usually most people need about 150 to 200. Her exam is unremarkable, but you notice they gave her T4 in this case. But you notice TSH is a little bit on the low side, so it's low, right? And free T4, right, is a little bit elevated. For our lab, free T4, the normal is about 4.5, 5, and this one is a little bit elevated. In TSH, it's not zero, but it's a little bit suppressed. Okay? So Rena says, what would we do? And you say, do nothing. That is the right answer. So the right answer is here, leave her alone. We're trying to do that, right? Are we not trying to give a little bit more to suppress? Right? So we're making her a little hyper. All right, so anybody know we don't give it forever. How long do we do that? 10 years. If the cancer hasn't come back in 10 years, then you're okay. So when she comes back to us next year, and hopefully the cancer hasn't come back, what are you going to do next year? What are you going to do next year? Decrease the dose to normal, right? We don't want to keep these people hyper. It's not good for their bone. It's not good for a lot of things, okay? But yes, next year, you're going to consider taking it down, okay? T4 is around 4, 4.5, okay? Everybody okay with that? All right, watch that. When do I give? I usually give just enough to keep everything euthyroid, right? Except when? When do I give more? When do I consider giving more? In patients post-thyroid cancer treatment. Okay, now Rekha says myxedema. Yeah, you're right. So we give in myxedema, we give so much, you know, we sometimes kill the patient, we give him so much thyroid hormones, but that's the only thing that we could do. Okay? But what I'm talking about here is post-cancer treatment. All right, great. Okay, let's move down a little bit and talk a little bit about hypercalcemia. I want to talk about hypercalcemia a little bit. All right, so tell me the main players. What's the main hormone? Let's do it here. Let's do it on the whiteboard so we can remember. All right. All right. So oh, I forgot that yesterday. All right. So here it is. So let's think about. So PTH is the main regulatory hormone, right, for calcium, right? So Francisco says magnesium. You're right. You got to have magnesium too. But parathyroid hormone is the main hormone, right? That activates the osteoclasts, right? You break down bone, right? There's the bone, and you release calcium. Everybody okay with that? So, you know, you don't go into tetany. If you miss your parathyroid hormone, you go into tetany because you can't mobilize calcium. So this is also important into understanding diseases that you have chronic parathyroid hormone secretion. Where do they get the calcium from? The bone. So if somebody had a parathyroid hormone adenoma, right, and it activates the osteoclast all the time, what does it do? Breaks down your bone. You get like osteopenia and osteoporosis and all that bad stuff. Okay? Now, let me ask you guys this. What's that? And some of you mentioned it. What else do we need for PTH to work? We need magnesium. Okay? We need magnesium. Okay? Otherwise, PTH doesn't work. All right? So This is important. Okay? Now, one other thing you guys need to know is, all right, this is what it does to the calcium. It increases calcium levels in the blood by breaking bone, right? Breaking up bone, right? But Julieta says, well, we need to know about phosphate. And you are correct, because what happens with phosphate is it decreases the reabsorption of phosphate, right? Reabsorption of phosphate, and so your phosphate decreases, right? Right. So it's a phosphate reducing hormone, a phosphate thrashing hormone. And where do you get rid of it? From your urine. Okay? Everybody okay with that? So what does PTH do? Right? Calcium goes up, phosphate goes down. Okay? Everybody okay with that? All right, so when you lower phosphate, you could actually mobilize calcium off the bones easier. So it's a way to be able to stimulate more calcium off the bones. Okay? All right. So now the other player is vitamin D. All right? So let's talk about vitamin D. So vitamin D is a very important hormone. All right? So where do you get vitamin D? The sun, right, through the skin. And where else? The gut, right? There you go. So you get it from the skin and the gut, right? From the small bowel. You got to get it in the food and be able to absorb it in the GI tract, in the small bowel. So right away, you guys know two ways you could get vitamin D deficiency. What are they? I just told you. GI. So if you have a malabsorption syndrome, and there you go. Kaplan says no sunlight. Yeah, so you know they did a study in people living in long-term facilities, older people. They didn't get a lot of sunlight. Guess what they all had? Vitamin D deficiency. What do people with celiac sprue get? We'll talk about this on Saturday. Vitamin D deficiency, right? How about Whipple's disease, right? There too, right? Vitamin D deficiency. So small bowel disease and lack of sunlight cause vitamin D deficiency. Okay, you guys are still not done. Even if I absorb it, it's not active, right? So I have to activate it at 125. So liver and kidney. All right, so now you got two more sources of vitamin D deficiency, right? Liver and kidney, cirrhosis and some kind of kidney damage, right? So that's my differential. My differential diagnosis when I find vitamin D deficiency, right, is exposure to sun, or, you know, people have some diffuse skin diseases sometimes, like psoriasis, they could get vitamin D deficiency, or malabsorption syndrome, or kidney failure, or liver failure. That's it. Okay, I mean, there's other ones too, but those are the basic ones. Okay? Everybody, well, right, because chronic pancreatitis is what? What's chronic pancreatitis? It's a malabsorption syndrome. In fact, chronic pancreatitis, as Sandra's talking about, you have massive malabsorption. You know, you could lose, 30 grams of fat a day. Very important. In fact, we probably see malabsorption in this country of vitamin D deficiency with chronic pancreatitis than we see with small bowel disease. Okay? Everybody okay with that? All right. So vitamin D increases your calcium absorption, right, and stuff like that. And unlike parathyroid hormone, it probably increases phosphate. Okay? All right. So, and what's the third player? What's the one that deposits calcium onto the bone? In fact, we use it in hypercalcemia. That's calcitonin, right? So calcitonin deposits calcium onto the bone, right? If you don't have calcitonin, there's some things may happen. Or if you have too much calcitonin, right? Sometimes you could get for a short while, right? Deposition of calcium to the bone and hypocalcemia. Okay? That's all. So we said parathyroid hormone is the main player. Remember what it does. With calcium and phosphate, it needs what? It needs magnesium. Okay, otherwise it doesn't work well. Right? And then we said vitamin D and then calcitonin. Right? So these are the major players. All right, so let's go back and talk about a little bit about the effect of hypercalcemia. All right, so hypercalcemia is very important, right? We're going to talk about a little bit about the differential diagnosis, but we need to know what it does. So if your calcium goes up clinically, you could get lethargic, you could get confused, you could get altered mental status, right? And people start to act weird. So neuro is a very significant presentation of hypercalcemia, the neuro findings. Then we could have GI, where the patient has abdominal pain and constipation. This is also important. And then renal, they get polyuria, polydipsia, and stones. Now you guys got to remember this, right? What did I say? Why do you get polyuria, polydipsia? All right, Sandra. Right, wonderful, because you get nephrogenic diabetes insipidus. Wonderful. So something happens with the hypercalcemia, something the calcium does to the vasopressin receptors, right? So the vasopressin doesn't work well for some reason, it messes it up, right? And these patients develop polyuria, polydipsia. And then you could have cardiovascular events like arrhythmias, short QT, and then some other ones, but these are the basic. We have to know the etiology here. Very important. Hypercalcemia etiology, they're going to ask questions. Got to know the differential. All right, number one, the most common cause of hypercalcemia across the board is hyperparathyroidism. All right, so what's that? What's hyperparathyroidism? I really mean primary hyperparathyroidism, right? So let me put this in here because you guys are going to ask me, right? It's primary, right? So you either have hyperplasia, right, or you have an adenoma, right? So 75% of the times, right, it's an adenoma. 20-25%, it's hyperplasia. Maybe a couple percentage points, it's cancer, right? One of those. Okay? Everybody okay with that? All right. Number two is malignancy. Malignancy is very common. So when we see somebody with hypercalcemia, we always worry. We worry about things like squamous cell cancer, right? Causing what? Parathyroid hormone-like peptide or parathyroid hormone-like protein. That's one way. The other way, you could get it like in multiple myeloma with multiple bone mets. So you got either a lot of bone mets and you secrete all these hormones locally, or you secrete PTH that activates what? If it's PTH-like, what does it do? It activates the osteoclast and causes hypercalcemia. Okay, very good. All right, so malignancy causes malignant hypercalcemia. What does that mean? Severe, right? The more severe the hypercalcemia, the more likely it's cancer. Okay? No, that's a good question. So the PTH-like peptide does everything that PTH does. There's only one thing it doesn't do. Anybody know? It doesn't get picked up by the assay. So when I look at my levels of PTH, if they're elevated, I know they only came from what? The parathyroid glands, right? That's right. If they give you just PTH, right, and it's elevated, you know it's primary hyperparathyroidism. Right? Everybody understand that? So this PTH-like peptide, this protein, the newer PTH measurements, right, are so specific, they only pick up the PTH from the parathyroid glands. Everybody understand that? So this PTH-like peptide, if I measure PTH, PTH will be low. Okay, I got to look for PTH-like peptide. Okay? Everybody okay with that? All right. What do you guys think about sarcoid? What's sarcoid? What's sarcoid? A chronic granulomatous disease. What kind of granulomas do you see? Non-caseating versus caseating. That's TB, right? Okay. So how do people get hypercalcemia in sarcoid? All right. Zanova says activated. That's right. So they get like a hypervitaminosis D syndrome. So they activate the vitamin D, excessive vitamin D through the granulomas. Very interesting. So listen, I had a patient. She would get it in the summertime. Every time. Nobody could figure it out. Why? Because she would get more vitamin D absorption with the sunlight in the summer. Right? There you go. They get it usually in the summertime. Okay. A couple of other things you guys got to know. You got to know about prolonged immobilization. All right? Be careful. People living in long-term facilities, right, after stroke and stuff like that, there's prolonged immobilization, right? And they develop hypercalcemia. Nobody understands that, why this happens. There's a lot of theories, but there's a lot of questions. All right, so just know about it. This is a possible question. Hospitals, long-term facilities. Then there's this disease called familial hypocalciuric hypercalcemia. Anybody know about this disease? Right, so it's not really a disease. People are asymptomatic actually, right? So what happens in the kidney? What happens in the kidney? In the kidney. Well, it manifests by hypercalcemia. Right. So basically, these people have a low calcium excretion. Right. There you go. Maggie said it correctly. It is the only cause of hypercalcemia with a low calcium excretion. Well, think about this, right? If you have high calcium in your body, right, what does your body do? Let's say you have hyperparathyroidism or malignancy. You spill it out. So high calcium in the body, high calcium in the urine, right? Except this has a low urine calcium. Why? Because that's where the problem is, right? That's where the issue is. Everybody okay with that? That's right. Because why? Rekha says, but in this case, right, the calcium is high, but the excretion is low because that's what causes the hypercalcemia. There's a receptor that's a problem there, right? So they don't get rid of enough calcium. Everybody understand that? You retain calcium. Okay? All right. You guys are all over this. So look at here, though. Be careful. Familial. All right. What does familial mean? It runs in families, so genetic, right? Hypocalciuric, right? So the name gives you the answer here. Low calcium in the urine. And that's what causes the hypercalcemia. Okay? Listen, for our purpose, this is a benign disease. Can you guys remember that? Benign disease. Right? You don't have to do much. You don't have to do anything, actually. Okay? Some people say, give it a furosemide or something like that, or, but it's fine. Okay? All right. And remember certain drugs, right? No. I don't know of any cardiac problems, right? So sarcoid gets treated with prednisone, right? Sarcoid gets treated with prednisone. Hypercalcemia associated with multiple myeloma, right, gets treated with prednisone. I don't know about familial hypocalciuric hypercalcemia. I've never heard about prednisone. Okay? There. All right? Everybody okay with that? But we got to know this right here. Hydrochlorothiazide. Okay? So remember, furosemide has calciuritic effect, right? Hydrochlorothiazide retains calcium, so you could get hypercalcemia. Everybody okay with that? All right, so what's our differential diagnosis here? Primary hyperparathyroidism, malignancy, sarcoidosis, immobilization, familial hypocalciuric hypercalcemia, and drugs. 6 things. Okay? Everybody okay with that? We got to remember this differential. All right, yeah, and hyperthyroidism could do that. I didn't mention it. They've never asked that, but it's nice to know. Okay, there's a lot of other ones. Okay, I don't want to go through the differential diagnosis because we're going to get so some of you are quoting some other stuff that's important that we're going to cover in other ways. So Zainab says milk alkalism. Yes, we don't see a lot of it anymore, right? Because people know about it. But yes, okay, everybody okay? But these 6. The reason I told you is because they make up about 97% of the cases. Right? So if you know this differential, you're good. You take care of most of the stuff you see and definitely most of the stuff that we're going to talk about for the boards. Okay? All right. So how do we manage hypercalcemia in the hospital? All right. So look, why did this patient come into the hospital or the emergency department? Because the hypercalcemia was severe, symptomatic, Rekha says. That's right. So it can't be just benign, little hypercalcemia. This was severe. Okay? So CNS, a lot of GI, a lot of confusion, stuff like that. Okay? All right. So what did I say? The more symptomatic, the more likely it's what? The more symptomatic the hypercalcemia, the more likely it's cancer. That's how you think about it. So the worse the hypercalcemia, the more worried you become about cancer. Everybody understand that? Can primary hyperparathyroidism do that? Yeah, of course it can. But the worse the hypercalcemia, the more I worry about cancer. Okay? All right. So what's the treatment? All right, look at this. They're dehydrated. Remember, because they got nephrogenic diabetes insipidus? So what do I give them? Fluids. What's number 2? Fluids and fluids. Okay? Fluids and fluids and fluids. A lot of fluids, right? Everybody get it? What's the primary? What's the cornerstone treatment of symptomatic hypercalcemia? Fluids, fluids, fluids. What do we give in medicine? Normal saline. Okay? Everybody remember that? All right, so now you guys are good to go for step 3 now, too, if you remember that. All right, so if I give fluids and I give fluids and fluids, right, guess what? What may happen to the patient? They may get a little bit, right? Fluid overload. All right, so there you go. You guys got it. So a part of the treatment is when I give a lot of fluids, right? A couple of liters, I'm going to give a touch of furosemide. Furosemide has calciuritic effects. To do what? To, take out some of the fluids. Okay? Everybody okay with that? Look, be careful. they're not going to ask you this in step 2, but they will definitely ask you in step 3 in the boards of medicine. They say, how do you give normal saline and furosemide? You give normal saline first. Don't write furosemide right away because the nurse is going to give them both at the same time. And if you give furosemide and this patient hasn't gotten enough fluids, you know what you're going to do? You're going to get them more dehydrated. Okay? Why don't we give hydrochlorothiazide? No, not the nurses are not bad. You wrote the orders. You wrote the orders. Give 1 liter wide open, right? And then give furosemide. The nurse doesn't know. They give them both at the same time, right? You don't give hydrochlorothiazide because it increases calcium, right? I know it's always our thing. The nurses do everything. Oh, I love that. My residents are great. Oh, the nurses do it. Right? So we could only give here furosemide, right? Not hydrochlorothiazide. Hydrochlorothiazide increases calcium in the body, right? Because it reabsorbs. Furosemide has a calcilytic effect. Okay? All right. So now, do you have anything else you could give this patient? So think about, look, if it's cancer, it's hard to get this patient's, calcium down and keeping it down. You may get it down with the normal saline, but then you stop the normal saline and then it bumps up. Okay, so the answer is I still have a couple of things, in my treatment, calcitonin and biphosphonates. So look at here. If I look at percent, right, of effect, right? So you see. This is day 1, day 2, right? Day 3. Okay, that's right. So Sandra says calcitonin works first, right? So there you go. This is your calcitonin, right? And what do you notice? Right, so it peaks the first 24, 48 hours, and then it goes away. So this is calcitonin, all right? And this is the biphosphonate, right? This is the biphosphonate. So, right, it starts working about 48 hours, right? And then it's more sustained, right? So this is, let's say, pamidronate or one of the other biphosphonates. Okay? Everybody okay with that? So why do we use both of them sometimes together? Because the biphosphonates take 48 hours to start working. Right? So I got to use calcitonin before that. Why don't I just use just only calcitonin? Because it goes away after 48 hours. Okay? Right. So the protocol is do your hydration first. Yeah, so kind of like warfarin and heparin, right? So do your hydration first, right? And your furosemide when you give a couple liters. If you can't control the hypercalcemia or it comes back, right? Sometimes you can control it just with fluids, right? Then you think of using a combination of calcitonin and biphosphonates. Okay? Everybody okay with that? So we don't have a lot of things here. Yeah, but you give them both together, right? You see that here? I gave them both together. You guys see that? Both together. Okay? Okay, very good. All right, everybody feel comfortable here? What's the cornerstone treatment of hypercalcemia? Fluids, 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 and after I give a lot of fluids, what do I give a touch of? Not before, after furosemide. Okay? There you go. Give furosemide later. Okay. So I want to talk a little bit about hyperparathyroidism and finish off with hyperparathyroidism. So hyperparathyroidism, I told you, about 70-75% of the times you have a single adenoma, right? So it kind of looks like this. Here's the hypertrophied parathyroid gland, and here's the other 3 that are normal. In fact, they're not normal. They're suppressed, right? So they look smaller, okay? That's the single adenoma business. about 25% of them, or 20% of them, depending on which study you read, you get for gland hyperplasia. Right? That could get tricky for the surgeon sometimes. And then I said a couple of percentage points for parathyroid cancer. That is rare. Hyperparathyroidism can be part of the multiple endocrine neoplasia syndrome. So MEN1 has hyperparathyroidism, pituitary tumors, and pancreatic tumors. So parathyroid, pituitary, pancreatic tumors. Now, you guys remember what kind of pancreatic tumors are we talking about here? So this is important. We're going to cover this when we talk about the GI stuff, right? So this is a gastrinoma, not an insulinoma, a gastrinoma, which causes this thing called the Zollinger-Ellison syndrome. I like to call it a gastrinoma, so I remember, right, what it secretes. Okay? Everybody okay with that? Okay. Very good. Or it could be part of multiple endocrine neoplasia too, right? Hyperparathyroidism, right? And then you got pheochromocytoma and then medullary cancer. This is the type that sometimes runs in families that we were talking about before. Okay? Everybody okay with that? So men 1 and men 2. Got to remember that a little bit here. All right, so now we diagnose it with elevated PTH. All right, so look at this. Remember what I said about this? What did I say about PTH? When PTH is elevated, it can only come from one area. What's that? Only from the parathyroid gland. So one of the first tests I get in the evaluation of hypercalcemia is I get a PTH level. All right, so look at here. If my PTH is elevated, right, okay, there's only one thing for our purpose anyway, right? It's primary, right? Everybody okay with that? If it's low, all right, so what do I start to think about now? What are possibilities? Cancer, sarcoid, other stuff. Okay? Everybody okay with that? All right, so primary hyperparathyroidism is really a surgical disease. Okay, so if you have somebody that's older, that has comorbidities, you may forego surgery, but surgery is really for anybody that's symptomatic and especially young patients. Right? So be careful, because if this guy is asymptomatic and they're 35 years old, you're going to leave them, with the parathyroid gland, they're going to live another 35 years. What's going to happen to their bone 30, 35 years later? They're going to get wasted. Right? So you gotta treat this disease, especially young people, right? Symptomatic patients. Okay? All right. So what if the guy's 85 years old? All right, and has comorbidities and doesn't have any symptoms? Okay, you could watch that guy. Okay, everybody else gets treated. Okay? All right. Last thing here. Anybody know what this hungry bone syndrome is? What's this business? Not Paget's disease. Hungry bone syndrome. All right, so let me show you guys. Look at here. It's after surgical resection. That's right. The bones pick up all the calcium after surgery. There you go. You guys got it. So look at here. So this is, I have an adenoma, right? So now the surgeon comes in and takes it out. Okay? They take it out. So what happens now? The guy goes from hypercalcemia, right, to hypocalcemia. There you go. Low calcium, hypo. So this is, I had a patient when I was an intern that we were following on the surgical service, and the nurse calls me and says, look, there's something wrong with this guy. He's winking at me all the time. That's what she said. And I went over. I'm serious. And I went over, and this guy was twitching a little bit. I tap over here and he starts twitching more, and then I put the cuff on, right, and he's getting latent tetany. So this guy started off with a calcium of 12 and he had gone to 5.5. All right, so tell me, why did this happen here? Why does hypocalcemia occur after the resection? But why does it happen though? The bones take it up. All right, David said it better. So the truth is that bones take it up, but why didn't the bones take it up before? Because you had parathyroid hormone. Now, look at here. You got only these guys right here, and they're not working well because they're chronically suppressed. See, this high calcium is suppressing them. They're atrophied, right? So if they're suppressed, right, what happens? There's nothing that could stabilize calcium in the blood. So the bones eat up the calcium. Okay? Right, so mild hypercalcemia, right, may become severe hypocalcemia. Right? They started off hyper, right? And then, see, hyper, right? And then they became hypo. Okay? Everybody understand that? They started hyper, you did the surgery, right? And then this patient became hypo. Everybody understand that? Okay, so now I'm going to ask you guys, how do we manage this? And then we'll take a break. What do we give always when people have severe hypocalcemia that is symptomatic? IV calcium, right? IV calcium. Guys, hold on. We don't have hypercalcemia now. We have hypocalcemia. If we went from hyper to hypo. We give calcium gluconate. Okay? Everybody understand that? Oh, hold on. 1 minute. I want to make sure. Let's take a break. Well, let's take a break for 10 minutes. Then we'll come back and I'll explain this. Okay? Everybody okay with that? All right. So it's after surgery that this happens. You started hyper. You became hypo. Okay? All right. Let's take a 10-minute break and we'll come back and we'll sort this out. I promise you. All right, so we talked about all this stuff here. Oh, okay. All right, I'll see you guys back here in 10 minutes. All right, everybody. Before I want to explain exactly where we left off. I saw somebody before and I couldn't find it. I tried to scroll up, but when we get a lot of responses, I can't find it. So follicular cancer, I don't know if there's a mistake at some point, but please look, follicular cancer probably makes about 15% of all thyroid cancers. Okay? So we said about 70%. No, no, it's not. Follicular? No. Maybe if it says 2%, they must have missed a zero or something like that. That's a typo. So about 70% is papillary. About 15% is follicular. I'll look it up and make sure that's the case. Okay? No, anaplastic is not 10%. Anaplastic is the rarest with medullary. Okay? Okay? That's right. So Minko said it correctly. It's 70% papillary, follicular, about 15%. All the others together, right, are maybe about 10-15%. Okay? Everybody okay with that? All right. So look, let me explain where I left off. So look at here. You have a parathyroid adenoma, right? Follicular cancer, right, is about 15%. Okay, let me explain hungry bone syndrome. Okay, so look at here. That's the bad boy, right? That's the one that secretes PTH. So PTH, remember, I think you're the only one, Mincho, that has a hard time following me. I don't think it's anybody else. So look at here. I'm activating. Yeah, I had to get that in there. You know? Yeah. If you stop typing things all the time, you would follow me and follow the book. So look at here. So I'm activating the osteoclast here, right? And I'm releasing calcium. Everybody okay with that? Well, look, this calcium here has negative feedback back to the normal thyroid glands, right? So that's why these are smaller than normal, because they're chronically suppressed because of the hypercalcemia. So what does this guy come in with? He comes in with hypercalcemia, right? Everybody understand that? This patient has primary hyperparathyroidism. Everybody clear on that, right? All right, so look at here now. So we do surgery on this guy, right? And right now he's having elevated calcium, right? This is why we do. That's how we picked it up. That's how this is why this guy developed symptoms, right? So we send him to the surgeon. We do, they image the neck and then make sure they see the size of the parathyroid gland, and they remove this guy here, right? All right, so see, Rena says, When you take away the adenoma, you don't have any parathyroid hormone. So where does this calcium all go? This calcium goes into the bone, right? No PTH, no calcium. It goes and deposits to the bone. You can't keep it normal because you don't have any regulation. You're basically having like you went from hyperparathyroidism to hypoparathyroidism. So what happens now? After surgery, the first 24 hours, so you go from high calcium, right, to low calcium because there's no regulation. Everybody understand that? Why is there no regulation? Because I took away the only gland that secretes parathyroid hormone. These guys here, they're in a dormant phase. They're sleeping because, I've been suppressing them for years. They need a couple of days to recuperate. Everybody understand that? So number one, after I do parathyroid surgery, where do I keep the patient for a day or so? Where do I keep him? I keep him in the hospital and watch his calcium level. There you go. I measure calcium levels in the first 24, 48 hours to make sure that this patient doesn't develop hypocalcemia. That's right. So the hyperfunctioning gland is big, right? It's the hypofunctioning glands that are small here. Not every patient we have to give calcium. Every patient we have to monitor for 24, 48 hours in case we need to give IV calcium. Right? Everybody understand that? It's the first 48 hours. If after 48 hours you're okay, you're fine. If your calcium level stabilizes. Okay? Everybody understand that? So what is this called? This is called the hungry bone syndrome. Everybody understand that? Hungry bone syndrome. It's not really about hungry bones. What is it about? It's about lack of PTH. That's what it's about. They called it hungry bone syndrome because they couldn't explain it decades ago. All right? So it rarely happens. I like some of you ask some questions. Can it happen after 48 hours? Rarely. So most people say, look, if you're okay after 48 hours, your calcium is okay, I could discharge you. Okay? Very rare. There have been some reported cases, but it's rare. Okay? Everybody okay with that? All right. You guys feel good about it? We have to know that. So what do we do after parathyroidectomy? Keep them in a hospital and monitor their calcium levels. What if they get tetany? What if they get Costexine and Trusosine? What do I give them? IV calcium. Which one did we say? Calcium gluconate. You could use other forms too, but that's good enough. Okay? Okay. A couple of things about hypocalcemia. All right. So number one and most important, the first thing I look at when I find hypocalcemia is I look at the albumin level. Okay, so with hypocalcemia, before you start thinking about the $1 million workup, look at albumin levels. Okay, why is that? Because high calcium levels are just like the thyroid hormones. So 40% to 60% of your calcium is bound to albumin. There you go. 40 to 60%. Okay? So what does that mean? If something happens to your albumin, right, then what happens? Then your total, see, I measure total calcium here. I don't measure free calcium. You can measure free calcium, and you got to ask a special test for it. You got to do it in the ICU lab. When we measure from the comprehensive panel, right, we get total calcium. We don't get ionized calcium. So we have to do what Natalia said, need to correct for the albumin. All right, now anybody know the correction? This is a good one for you guys. This is good. All right, Natalia said 0.8. There you go. So for every drop in albumin by 1 point, so albumin drops by 1 point below 4 because that's normal, right? 4 is the normal one. You don't have to remember it, but it's nice to remember it. So for every drop of albumin below normal by 1 point, you have a drop of calcium by 0.8. Okay? Everybody understand that? Everybody clear? So look at here. This is what you're measuring. Okay? This is total calcium. Everybody understand that? We don't care about total calcium, but that's what we measure. We really care about right here, the free calcium. We always have to look at this correction. This is what we care about, but we don't get this. We get this plus this. Calcium plus albumin. This part right here is calcium plus albumin. Everybody see that? So what if I lose 2 grams of albumin? It's not a calcium problem, but what happens if I lose 2 grams of albumin? I get nephrotic syndrome. This area shrinks, right? So now look at my calcium. My total calcium is decreased. You see that? Everybody see that? How about my ionized calcium? You guys don't see it decrease here? That's normal, right? You guys don't see it that it's decreased? So remember, this guy lost albumin, so this decreases here. There you go. Total decreased, ionized, no change. Oh, it was a bit slow. Okay, I got it. Okay, everybody okay with that now? All right, so I got to make the correction, right? Total decreased, ionized, normal. But what do I measure? Total, right? So when somebody says, hey, this guy's got a low calcium, what's the first thing I got to do? I got to make the correction, right? What's the correction? For every drop in albumin below 4, the albumin drops by 0.8. Okay, so all right, let's see if you guys are paying attention now. Somebody comes to me with an albumin of 2. His calcium, right? Remember, I'm getting total calcium, right? His total calcium equals 6. All right? So what's his real calcium? Beautiful. Hold on. Maria, I didn't say this guy had an albumin of 4, went to 2, and he had a calcium of 6. Where does it go? I said this guy's got an albumin of 2 and a total calcium of 6 at the same time. Right? So his real calcium is 7.6, right? Which is normal. 6 is abnormal, right? 6 is low. So my resident said, oh, whoa, this guy's got a low calcium. And I said, well, let's do the correction for the albumin. And his calcium is normal. So it's not a calcium problem. What is it? It's a albumin problem. So I got to go back and take a look at his liver, his kidney, stuff like that. Okay? Everybody understand that? So look, this, they're going to have some question around it. Okay? It's a great clinical question for you guys. Everybody okay with that? All right, so you guys know that now, right? When you guys are on the medical wards, right, or on the surgical wards, you're always going to make that change. So when somebody says, hey, this guy's got a low calcium, he says, okay, hold on, let me check his albumin because I want to make the correction. Okay? All right, so this patient has really not true hypocalcemia, but it's pseudo, right? Everybody okay with that? So I make the correction. I say for every drop in albumin by 1 from 4, 4 is the normal, right? I drop my calcium by 0.8. Okay? So if this guy has an albumin of 2 and a total calcium of 6, right? Remember, if the albumin went from 4 to 2, then his total calcium dropped by 0.8 and 0.8. Okay? Very good. All right, so let's now talk about if his albumin was normal, then I wouldn't do any correction, right? Then it would be a true hypocalcemia. Okay? No, guys, what people are going to give you is what you get in clinical practice. So this is not step 1. What do you get in clinical practice? You get a comprehensive panel, and it gives you a low calcium, right, and an albumin at the same time. Right? Everybody understand that? So you got to say, okay, my albumin went from 4 to 2, then what's my real, right, calcium? You subtract the albumin, right, from 4. It goes down from 4 to 3 to 2. If the albumin is low, right, but the calcium is normal, you're fine. You don't have to worry about it, right? Maybe even a little bit on the high side if you do the correction. Okay. Everybody okay with that? I know, like, listen, we're not mathematical geniuses because we probably would have chosen to be in physics or something like that, but this is not that hard, right? Everybody okay with that? I used to get this wrong all the time. All right, so now let's talk about hypocalcemia, real, right? Real hypocalcemia. This is true now, right? So I checked my albumin because that's the first thing I do, and that was normal. Okay? All right, so what do I got now? Now I got true hypocalcemia, and I have to think about a couple of syndromes. So I have to think about hypoparathyroidism. Hypoparathyroidism. Well, when does this happen? When do you get hypoparathyroidism? Well, in the adult, it's usually some kind of surgical removal, some kind of trauma, stuff like that. Right? So what do I mean by that? You usually get that from the history, right? After total thyroidectomy, something like that. Right? So usually in the history we could get that. Okay? The other possibility is that you have enough PTH, but look at here, remember what we need? For PTH to work, what do we need? Magnesium. There you go. So okay, so you got to make sure you got enough PTH and you got to have magnesium for it to work. All right? And then the other possibility is vitamin D deficiency. We see it in this country most likely associated with renal failure, intestinal malabsorption, more rare, not exposure to sunlight, and cirrhosis. Okay? Everybody okay with that? All right. So now what they want us to know is this. So look at here now. So look at here. So first case scenario is a person with a low calcium. Okay? Right? This person got it because of low PTH or no magnesium. Right? So the PTH is low. Right? And this causes the low calcium. Well, what does PTH do to phosphate? Well, it gets rid of phosphate, but when there's no PTH, what happens to the phosphate, right? This usually increases. Okay? Everybody okay with that? So look at here. They may ask us on the USMLE a question about low calcium, and what you're going to need to know to answer it is to look at the phosphate. Remember, if a patient has primary hypoparathyroidism, low PTH, this causes a low calcium, but the phosphate is elevated. Why is the phosphate elevated? Because it's PTH that you use to get rid of phosphate, and you don't have it now. Okay? Everybody okay with that? All right. So this is what now? What did I just describe now? I described the hormonal pattern in a patient with primary hypoparathyroidism. This is the guy that had the surgical resection of the thyroid and then his glands got messed up, right? Or somebody that had trauma to the area or something like this. Okay? Everybody okay with that? All right. So the second scenario that's a little bit more complicated, and that's why you see this on the test, is you got calcium that's low, right? And this calcium is because a low vitamin D. So vitamin D, I don't know, you're in the Midwest and you're not getting any sunlight, or you got a malabsorption syndrome, right? Or something like that, or renal failure. But you got vitamin D deficiency and your calcium is low. All right, so what happens now? Well, calcium, when it drops, what does it do? It increases your PTH, right? So PTH here is increased. Okay, hold on. PTH is increased, so this patient has hyperparathyroidism. That's right. This person has hyperparathyroidism, but what is this called? What type of hyperparathyroidism is this called? Secondary. Secondary to what? Secondary to what? Secondary to the hypocalcemia, right? That's what drives it. Remember, the vitamin D doesn't drive your PTH. It's the calcium that drives your PTH. You know, remember we started saying PTH. Okay? Everybody okay with that? All right. So look at here now. You guys guessed it. If your PTH is constantly elevated, what happens to your phosphate? Your phosphate, this is, you guys told me it's phosphate thrashing, right? So it's not high, it's low, right? It's low. You get rid of it. You get rid of it. Okay? Everybody understand that? So when you got vitamin D deficiency that causes hypocalcemia or liver disease or something like this where you don't activate your vitamin D, you activate PTH, and this tries to stabilize the calcium levels, but what do you waste in the meantime? Phosphate. See, by wasting phosphate, what the PTH tries to do is basically try to have an easier way to mobilize calcium. Okay? Everybody okay with that? So this is hypoparathyroidism here. This is vitamin D deficiency here. Okay? Everybody okay with that? All right, so we have to know this. So they may ask us the use of phosphate, right, to decipher where the hypocalcemia is coming from. All right? So if it's low, it's a vitamin D problem. If it's elevated, then you don't have PTH or you have hypomagnesemia. Okay? Okay, very good. So let's go back here and talk a little bit about what we just said. So I said that with hypocalcemia, you could get neuromuscular irritability, like tetany, laryngospasm, cramping, and even sometimes seizures. A latent tetany could be seen with cross-text and Trousseau right? Tapping over the facial nerve and the guy gets twitching. Trousseau sign, right? You put the cuff on and the patient gets tetany, latent tetany again, right? And then cardiovascular, right? QT prolongation and stuff like that. And then we said, how do we evaluate hypocalcemia, right? We check the albumin, right? And make the correction, right? If the albumin is normal, right, then we have true hypocalcemia. And then we look at things like the PTH and the phosphate, right? So in hypoparathyroidism, I just showed you the PTH is low, the calcium, of course, is low, and the phosphate is high. In vitamin D deficiency, the PTH is high. Be careful. This is called secondary hyperparathyroidism. Okay, secondary hyperparathyroidism. What causes secondary hyperparathyroidism? Anything that causes hypocalcemia. And then the phosphate is low. Okay? Everybody okay with that? So in the acute stage, if the patient has significant symptomatic hypocalcemia, we give IV calcium gluconate. So this is in the acute, right? So if the patient is not symptomatic, then we usually treat maintenance therapy. We usually give oral calcium a couple grams a day, and then vitamin D. Be careful about this vitamin D. Okay, so look at here. This vitamin D, right, 4 USMLE is 125 vitamin D. And that's not the stuff you get, over the counter and stuff like that. It has to be activated vitamin D. Okay? Activated vitamin D. Everybody okay with that? Right? You don't want to do anything else. Okay? All right. So remember, what's the first thing we look at? In hypocalcemia, we look at the albumin. If the albumin is normal, all right, then what are the other two tests we get to figure out where the problem is coming from? Mariana says PTH, right? And we get the PTH, we get the magnesium, and the phosphate. All right, you want to get the vitamin D, that's okay too. All right, they don't give us the vitamin D. They usually give us magnesium, right? Phosphate, PTH. So between those, you got to decipher what this patient has. Okay? Everybody okay with that? No, if a patient has symptomatic hypocalcemia, right, the first thing you do is you give IV calcium. Okay? You give IV calcium. Okay? Yes, in asymptomatic cases, if the patient's missing magnesium, you give them calcium, vitamin D, and magnesium and stuff like that. All right, so remember we said maintenance dosage is 2 to 4 grams of calcium, oral calcium a day. with vitamin D, people give vitamin D, and if they're missing magnesium, you may consider giving magnesium, replacing the magnesium. Okay, so I want to talk about diabetes. In the last 15 minutes, I want to talk about diabetes. So, diabetes mellitus is a tremendous problem right now. And they talk about the increase in diabetes because the increase in obesity and the increase in obesity and diabetes in younger kids and stuff like that. So we need to know the difference between type 1 and type 2. So type 1 we call insulin dependent. That's not a good name for it, but it gives us an idea of what's happening. Patients with type 1 get an inflammation of the beta cells. What is this called? Insulinitis. And they develop fibrosis and scarring of the beta cells. And then eventually, they have no production of insulin. Basically, they have no insulin. Type 2 is an insulin resistant state, right? So what does that mean? What's an insulin resistant state? They produce insulin, right? Maggie says they have too much insulin, it just doesn't work. And this resistant insulin business, this resistance to insulin has to do with what? Anybody know what's the most, well, it's a receptor, yes, but Maggie and Mariana, answered, and Sandra, it's obesity, right? So it seems that the more BMI, the higher the BMI of the patient, the more obese the patient is, the more insulin resistant the patient is. So look at this. There's two things they may ask here. Number one, can we have diabetes with elevated insulin levels? What's the answer to that? Yes. What's that? Type 2. Right? Everybody okay with that? That's type 2, of course. All right. Number 2. What worsens diabetes control? Weight gain. What's a side effect of the medication we use? Weight gain. So see, it's kind of like a vicious cycle here. That's a big problem. The other thing they ask about is about outcomes. Who has worse outcomes? Well, look, type 1 is a more difficult diabetes to control. So overall, over time, it's much harder to control. Be careful. Watch what they're saying. If they're saying worse outcomes over time, probably type 1 does, right? But if they are talking about who has disease on presentation, who are they talking about? Who's got disease on presentation? What's the diabetes that could have disease on presentation, microvascular disease on presentation? It's type 2, right? Type 2, right? You don't have that in type 1 because the guy with type 1, how long have they had the disease before they come and see you? Type 1? When they come and see you, first time you diagnose them, they got it a couple of weeks. You can't live. Yeah, you can't live without insulin for more than a couple of weeks, maybe a month, right? So it presents with ketoacidosis. When they come with DKA, that guy had it for maybe a month, okay? Type 2 diabetes, though, how long have they had it? Who knows? 5 years, 10 years, who knows? Decades sometimes, maybe a couple of months, maybe, who knows, 5, 6, 7 years. That's right. So they've been insulin resistant for many years, right? So patients with type 2 diabetes could have disease upon presentation. All right, so now, who gets type 1 age-wise? The young, right? And how about type 2? Well, middle-aged people, right? All right, be careful. So now they've written different papers on, yeah, so this Modi business, you guys don't have to know. You guys, type 1, type 2, done. Okay, but look at this. What they've asked about is type 2 diabetes presenting early, what Julietta says. So obese kids with type 2, there's all these reports. I mean, it's crazy. So you have like 19-year-old kids with type 2 diabetes. All right, so look at this. What has happened because of childhood obesity? The curve has shifted to the left. What do I mean by that? People are getting type 2 diabetes earlier in life. So if somebody's 20 years old, right, 19, 20, 21, and they look like they have type 2 diabetes because they're a little bit obese, they got, high sugars and stuff like that, right? They got type 2. Okay? Don't think they can't get type 2. Everybody understand that? Okay, this is a big deal now. Type 2 earlier. Okay? All right, so let me ask you guys one more thing. Type 1 versus type 2. When we ask, do you have a family history of diabetes? Who do we really ask about? What are we really referring to? All right, very good. So we usually talk about type 2. Type 2. So if look at this. If an identical twin has diabetes, the chances of the other identical twin getting diabetes is 100%. 100%. So very strong genetics in type 2. Type 1, it's less. If you have an identical twin, it's about 50% chance of the other one getting it. Okay? That's right. So much less. So you guys mentioned before what happens in type 1. You get like a viral infection, right? In predisposed individuals, you get a chronic inflammation of the beta cells, and that's what causes the type 1 diabetes. Type 2 is insulin resistance. Something, different. Okay? Everybody okay with that? So there's going to ask something about this. All right? Be careful about this on presentation. So they may ask you guys, type 2 diabetes, right? When we diagnose them, what do? The answer is we send them to the eye doctor, right? When they come and see us, after they leave, you make an appointment to see an ophthalmologist because they could have vascular disease on presentation. Okay? All right, very good. We need to know a little bit about the definition and diagnosis. All right? So the test that has the highest reproducibility in terms of diagnosing type 2 diabetes and type 1, but type 1 usually comes in decay, is a fasting glucose. If the fasting glucose is equal to or above 126 on 2 separate occasions, right? So you like 2 separate occasions. We're talking about the outpatient setting now. We're not talking about somebody that came in with DKA, right? You got it on 2 separate occasions, 126 or above, right? You got diabetes. So the magic number is 126 or above. Everybody understand that? They're usually apart 1 to 2 weeks just to make sure this is not an outlier. Okay? Everybody okay with that? That's the most reproducible test. All right, so now one of you are going to ask me, wait a second, how about the fasting glucose? Over 200, right? That patient has diabetes too, but it's less reproducible. Okay? So you need 126 or above, fasting glucose 126 or above on 2 separate occasions. And then over 200 anytime. right? But that's less reproducible. So I had a guy one time, and he went and ate, a whole cake. All right, so his sugar was, 210, right? So, you can't always get you know, a good baseline when you do it like that. It's better to do the fasting glucose. Okay? Everybody okay with that? So what did I say? 126 on two separate occasions. All right. So now we have one more tool to diagnose diabetes. The other tool is the A1C. What's the A1C? Tell me about A1C. We're talking about diagnosing diabetes. So about 5-6 years ago, the Diabetic Association said, yep, you could use A1C. So Maggie says over 6.5, a glycosylated hemoglobin says the patient has diabetes. Okay, because you're measuring the glucose attached to hemoglobin, glycosylated hemoglobin. And what does that give you? It gives you a level that correlates with a mean sugar in the last 2 to 3 months, right? That's the right answer. So if somebody's A1C is 7, I know this guy's mean sugar in the last 3 months is something like 180, right? That's what it winds up to be, maybe 150, okay? If their A1C is 8, then it's 250. Okay, so basically long-term evaluation of the mean glucose. So this is important because the other question they asked you guys is what happens, right, with, glycemic control if I got it abnormal. All right, so you make some changes, but you repeat, the A1C 3 months later. The A1C is not going to change next week, right, because it gives you the mean the last 3 months. Why do we use 6.5? Well, Sandra says it nicely. Because 6.5 correlates to about 125, 126. Okay? Everybody okay with that? Good. So that's diagnosis. So all this time we're talking about diagnosis, right? But look at here. We use the A1C also for follow-up. Okay? So A1C to diagnose, A1C to follow how we're doing with treatment and if the patient is adherent. Okay, this question here, what are the objectives of diabetes treatment, is a big one. Okay, so the patient says, doctor, you're making me take all this medication, you're making me do this, that, and the other. What is it good for? All right, so Rena got it correctly. It's to prevent microvascular complications. So this is super important. When I do tight glycemic control, what do I prevent? Microvascular complications. Not macrovascular, only microvascular. I could only prevent them, I could only stop them by tight glycemic control. So what's microvascular complications? Okay, eye, renal, and what's the last one? So retinopathy, nephropathy, and neuropathy. Very nice. Eye, kidney, nerves. Okay? Eye, kidney, nerves. That's the only thing tight. Do you understand that? You either prevent it or at least you slow it down by doing tight glycemic control. So what if I said, how do you prevent a stroke in a diabetic patient? No. Hold on. Guys, we just said it. We said eye, kidney, nerves. Is that eye, kidney, nerves? All right, so you guys nothing. All right, now you get to the other side. So the stroke is not going to be benefit from what? From tight glycemic control. So it's something else, like what? You guys got it. Control blood pressure, lipid control, aspirin. That's right. There you go. It's not tight glycemic control. Cessation of smoking. Very good. Okay. All right. How about this? How about this? How about peripheral vascular disease in the large vessels? Good. Cessation of smoking. How about MIs? Heart attack. So my diabetic patient asked me the other day, I said, you gotta stop smoking if you want to get a heart attack. You gotta control your lipids. You gotta take an aspirin. Okay? All right. Everybody understand that? All right. So Apiska said, how about gastroparesis? Ooh, that's a good one. How about gastroparesis? What's gastroparesis? Is it micro or micro? That's neuro. So how do I control gastroparesis? No. Just tell me how I prevent it. I'm sorry. Glycemic control. There you go. How about erectile dysfunction? All right. So see, you go to the patient. See, Tyler, you got to know how to talk to the patient. You know, Mr. Jones, you're going to go blind. I don't care. Mr. Jones, you're going to go into renal failure. I don't care. And then you say, you may get a little erectile dysfunction. Right? He says, give me metformin. Give me anything, doctor. Right? So what's erectile dysfunction? Erectile dysfunction. Erectile dysfunction is autonomic, right? It's microvascular complication. Oh, see, I tell them, look, what's important to you is your eye, your kidney, right? Your nerves, and part of the nerves is erectile dysfunction. The guy perks up. You know, he didn't care if he goes blind, he didn't care anything, right? See? Everybody understand that? So we'll talk more about these, but everybody understands when I say I do tight glycemic controls, what am I supposed to see? I'm supposed to see, right, less microvascular complications. Okay? Everybody okay with that? Okay, wonderful. Let's take a 10-minute break and we'll come back and we'll talk more about this. Talk about more about diabetes and finish diabetes up. Okay, everybody. So before I start showing you a couple of cases of severe forms of diabetes, basically DKA and hyperosmolar hyperglycemia, I just want to summarize on what we said. We said when I treat patients with diabetes, my goal is to keep tight glycemic control. This tight glycemic control reduces the risk of microvascular complications, not macrovascular, only microvascular complications. So the eye, the kidney, and the different types of neuropathy. Okay? So be careful when they're saying, how do I prevent a stroke in a diabetic? How do I prevent an MI in a diabetic? We're talking about lipid control is a part of autonomic neuropathy. So remember, in diabetes, you get three types of neuropathy. We'll talk about them. So there's the peripheral neuropathy, the mononeuropathy, and the autonomic neuropathy. So can you guys give me, in all diabetes, it's the same. So can you guys give me examples of autonomic neuropathy? So erectile dysfunction is one of them. All right, erectile dysfunction, impotence. Okay, anything else? Gastroparesis is another one. Peripheral neuropathy is peripheral neuropathy. It's not autonomic neuropathy. Diabetic foot is peripheral neuropathy. So gastroparesis and GI stuff. Hypotension, right? Orthostatic hypotension, right? There you go. Those are parts of autonomic neuropathy. Okay? Okay. So we want to talk a little bit about the acute complications of diabetes. So we gotta know this stuff here. So look at here. I'm going to walk you through this case. A 19-year-old man comes to the emergency department with lethargy for about 2 days. He's been constantly thirsty and urinating. He's got a low-grade fever, a low blood pressure, and a high pulse. Right? Everything else is pretty much normal, except that his heart is tachycardic right? And he's a little bit, confused. Okay? Everybody okay so far? So this could be anything, right? This could be anything. All right? But this business about thirsty and urinating always makes you think about diabetes, right? And what's the most common form of diabetes? It's diabetes mellitus. So what do you guys think about this? The glucose is definitely elevated, 426. Okay? The potassium, it's a little elevated also. The BUN and creatinine are elevated. And look at here, the bicarbonate, what's a normal bicarbonate? 24, very good. All right, 22, 24. Okay, this is definitely decreased. Everybody see that? Right? Definitely. Okay, so now with the low bicarb and the elevated glucose, what do you guys think about? You think about acidosis, metabolic acidosis, and you think about anion gap acidosis. All right, can you guys tell me? Yeah, so Rika says blood gas, so that's what you would ask for in this case, a blood gas to confirm. But can you guys measure the anion gap? What's the anion gap in this patient? It's high. Olia says it's 18. Right, so it's 18. Okay? 18. Okay, so the way you got it is you subtracted, right, sodium. Forget about the potassium. Don't use the potassium for the anion gap. Some people use it, but, you subtract the negatives from the positive, right? So chloride plus bicarb, and you subtract that from sodium. Okay? Everybody okay with that? So this patient's anion gap is 18. All right? Anything over 12 is abnormal. So now you got a high sugar, a low bicarb, elevated anion gap. Okay? All right, what do you guys think? What's this patient have? 19 years old. He's got DKA until proven otherwise. So you want to get the ketones in the blood and the urine to confirm, that's fine with me. Okay? All right, so I have two questions for you guys. Okay? Why are they getting chest x-rays and blood cultures and urine cultures and all this business? All right, so Rena says to rule out infection, right? So commonly, patients coming in with diabetes complications and diabetic emergencies, they have a precipitating cause, like an infection. This guy had a low-grade fever, so he had a urinary tract infection. That's legitimate. All right? Where do I treat this patient? Do I admit him to the hospital? Hospital. Where? Usually in the ICU. All right. So it goes in the ICU. All right. So what does he get? What does he usually get? What's kind of like the cornerstone treatment? What does he have? Well, hold on. Let's one step back. So he's got DK, right? Everybody said he's got DK. So what type of diabetes does he have? 1. For our purpose, it's 1. DK equals 1. So what does that mean? He doesn't have any insulin. So what do I have to give him? What does he have to get? Insulin plus hydration, right? That's it. Okay? Now, some people with a very low bicarb will give bicarb. You guys don't have to give ever bicarb in step 2. Okay? If you're giving bicarb, you're probably answering something wrong. Okay? Everybody okay with that? All right, so 2 more quick questions for you guys. Why is his potassium elevated? Why is his potassium elevated? Mariana says acidosis, right? And Maggie says no insulin, and you are both right. So it's an intracellular to an extracellular shift because the lack of insulin, right? Lack of insulin, that's number one, and the acidemia. Okay? All right. Why is his BUN creatinine elevated? Likely. I mean, we could only speculate. Why does he have elevated BUN creatinine? Likely from the dehydration. Okay? Everybody okay with that? All right. So all these points that we made are very important clinical points for the exam. Right? The anion gap with the low bicarb, they may not give you an ABG. You're supposed to do the anion gap and sort that out. Anion gap acidosis with elevated glucose. This patient has DK, has type 1 diabetes. Look for precipitating causes. Okay? Put him in the ICU, give him insulin, give him fluids. Okay? Everybody okay with that? So this DK business, there's got to be one or two questions on the USMLE. There have to be. Okay, very good. Okay, so we talked about this. So look at this case now. A 62-year-old man is brought to the emergency department because of confusion. His wife had not noticed any fevers, chills, or vomiting or nausea. He appears lethargic. He's arousable. His temperature is okay. His blood pressure is a little bit on the low side. His pulse is a little elevated. His lung examination is normal. His heart is tachycardic. There's no focal deficits. The rest of the exam is unremarkable. So you're saying, okay, 62-year-old guy who is confused. So, a million things could be going on. Metabolic, infections, drugs, anything, right? Doesn't look like a stroke because he has no focal deficits, right? So there's a million things that could be going on with this guy. All right, so look at the labs. Glucose, 1,118, right? Potassium looks normal. BUN creatinine is elevated. Bicarb, what do you guys think about the bicarbonate? Normal. Okay? All right. Can you guys do the anion gap? All right. Maggie and Vikram, they've done it already. 6. That's right. Right? Sodium minus chloride and bicarbonate. 6. What's that? So anion gap here. Anion gap. Normal. Less than 12. All right. We're looking good. Right? So with a sugar of 1,000, right? Normal anion gap, normal bicarb. So what does this patient likely have? What is the syndrome called? Hypersmolar hyperglycemia or hypersmolar coma, they call it sometimes, right? So what type of diabetes does this guy have? Based on what I told you, this guy has, by definition, 2. All right, do you guys know that this guy has a worse prognosis than the patient with DK? Because this is an older patient, because they have more comorbidities, because his sugar is 1,000 and he's severely dehydrated and he's 62, he's not 19. All right? The ketones are negative. That goes along with type 2 diabetes. All right, so look at here. Why did they do all this stuff? EKG, chest x-ray, blood cultures, urine cultures, etc., etc. What are they doing? They're trying to just do more tests like we do here in America all the time. We get a million tests. Why are they doing all this stuff? All right, look for precipitating causes. All right, Sandra said something about the EKG. Why are they doing EKG? Because you could get silent ischemia. Do you guys know about that? Patients with diabetes, they get neuropathy and they don't develop any chest pain for some reason. They think it's because of the neuropathy. Okay? Very important. Okay. All right. So number 1, what's the treatment? Where do I put this patient? ICU. What do I give this guy? This guy's even more dehydrated than the other guy. You know why? Because look at his sugar. So he gets a lot of fluids and insulin. All right. Let me ask you guys, let's see who's paying attention. So what is his serum osmolality? I don't need an exact number. I need to know if it's high, normal, or low. High, 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 high. Why? I thought sodium is normal. It's actually low. The glucose and the BUN, remember, those are the two factors. I said if both of those are normal, then it's 2 times your sodium. His glucose is off the wall, right? So very high osmolality. Okay, everybody okay with that? How about his BUN creatinine? What do you guys think about the BUN creatinine? What do you think about that? High. So maybe pre-renal, right? Okay, now this gets more complicated though. Catherine says the ratio is over 20 to 1, which it makes it more likely to be pre-renal. But even if this guy never had diabetes before, could this be intrinsic renal disease from diabetes? Yes. Yes. Why? It's type 2. How long has he had it? He could have had it for years. That's exactly right. We don't know. He could have had it a couple of months. He could have had it 10 years. Nobody knows. So he could have intrinsic renal disease, but as Catherine said, hopefully not. His ratio is over 20 to 1, which points more towards pre-renal. So hopefully with the fluids, this is going to normalize. Okay? Everybody okay with that? All right. So they got to ask you these 2 cases. They have to ask you these 2 cases. What did you guys notice about the level of sugar? Where is it more high? Well, that's obvious, right? I'm asking an obvious question. In hunk, in type 2, that's typically where it's in the thousands sometimes. All right, so why am I asking this question? Because, hold on, because type 1 is not about the sugar, right? What is it about? What's the problem with type 1? It's not about the sugar level. It's the lack of insulin, so you can't utilize carbohydrate. You don't have insulin resistance in type 1. No. You have no insulin in type 1, right? So you don't have insulin, right? Type 1. So what happens? You can't utilize carbohydrates. What do you utilize for fuel? What do you break down? Fatty acids and all that stuff, lipids, fat, and that's how you get the ketones. That's what kills the patient, right? That's what kills the patient, the acidemia. So your goal when you give insulin is to what? It's not so much to get the sugar down, it's what? To clear the fatty acids and the ketogenesis. To be able to utilize carbohydrates and stop utilizing what? Lipids, right? Fats and stuff like that. Okay? Everybody understand that? So this is a tremendous important point. Okay, very good. All right, so we talked about this, where to admit them. All right, so now let's talk a little bit about the chronic complications. We've talked about them before, but we want to talk about them more here, and we want to get a couple things straight before I tell you more about the treatment. All right, so microvascular complications. Eye, kidney, nerves. Let's talk about the neuropathy first. The neuropathy may be due to one of 3 types: a mononeuropathy, an autonomic neuropathy, or a peripheral neuropathy. A mononeuropathy means one nerve is affected, right? So the patient has a wrist drop or a foot drop. So I had a diabetic patient one time, comes in, he says, "Hey, look, doc, I'm dragging my foot." You know, he developed a foot drop. It's because it picks off these single nerves sometimes. A very common form of mononeuropathy is this. So here's the eye. And this guy comes in with ptosis, right? Ptosis, right? You guys see that? All right, so how do I know it's not Horner syndrome, right? How do I know it's 3 paralysis like you guys said, like Minko and Maggie mentioned? You guys are right. This is 3. No, no, not from the x-ray. Come on, I got to be a better clinician than that. How do I know it's not Horner's? Because this patient doesn't have meiosis. What do they have? Look at the eye. Look at the eye. I drew it here on purpose. It doesn't have meiosis. It has ptosis without meiosis, right? Only ptosis. That's right. So only ptosis usually means cranial nerve 3 palsy, right? Remember the 3, the pillars? They hold the eye up. Okay? Everybody okay with that? You guys got to remember this because they're going to ask about this. Okay? What's a common nerve? Cranial nerve 3. They love to ask cranial nerve 3 with diabetes. Okay. Now you guys got to help me out here. Autonomic. Tell me about autonomic. What's autonomic? Gastroparesis. Erectile dysfunction. Right? What's the other one? Hypotension. There you go. Okay? Wonderful. All right. And then how about this peripheral? This is the most common one. This is the most common one. What's this peripheral? What is it? So this is the diabetic foot that Doug is talking about, right? So you guys ever hear the term stocking and glove? Good. So Sandra said stocking and glove neuropathy. So it's like the gloves, right? Where the gloves are in the hands and the stockings, right? The socks. That's the areas it affects, right? So you guys, when they come to the office, is very important that you look for sensation, right? So do you guys know the test that they do now in the offices to make sure they don't have neuropathy, to pick up early neuropathy? So pinprick, it's a form of a pinprick test, right? So what is that called? Monofilament. All right, that's the right monofilament test. That's it. So they use these little brushes, right, to see if the patient has sensation. Very good. Monofilament. Okay? Very good. Monofilament. There you go. Okay? That picks up early neuropathy. All right? And then number 2 is renal. Renal is super important when you guys do nephrology and you talk about end-stage renal disease. You're going to find out that 2/3 of the patients in end-stage renal disease in this country have hypertension or diabetes or both. So this is an important complication of diabetes. They develop end-stage renal disease. They ask us, how can we pick up the earliest form of renal damage? The answer is, I check the urine for microalbuminuria, right? Urine microalbuminuria. So look at this. I'm checking the urine to catch it early before it becomes what? Before it becomes macro, and I could see it in the urine, in regular urine, just by, checking a urine analysis. See, this microalbuminuria is a special test. You got to get the urine, and they got to check for the special test where they look for early albumin. Okay? Everybody okay with that? It's usually over 25 or 30 that's abnormal. You guys, you don't have to remember that, but they'll give you the normal, and if it's above that, it's abnormal. Okay? All right, be careful now. Somebody showed me in one of the courses this case where the diabetic patient had macroalbuminuria. So they did the urine analysis, and they had macroalbuminuria. Do you have to do microalbuminuria in that patient? No. Why am I going to do it? Yeah, maybe additional disease. I don't know. But the bottom line is, whether it's from diabetes or something else, or advanced disease, what's the moral of the story here? If you got macro, yeah, you passed the stage. You don't have to look for micro, right? Everybody understand that? All right, why is it important that we catch microalbuminuria and albuminuria early in diabetic patients? Because it's treated. It's treated. Okay? You could reduce the progression or slow it down by using ACE inhibitors or angiotensin receptor blockers. ACE inhibitors or angiotensin receptor blockers. So what do? They reduce the proteinuria. Okay, now I said ACE inhibitors there, so they are first. For my boards, for USMLE, step 2 and 3, I use ACE inhibitors first. I use angiotensin receptor blockers only when I can't use ACE inhibitors because of the cough. Okay, because they're no better and they cost more and etc. etc. Okay, everybody okay with that? So ACE inhibitors, can't use that, go to ARBs. Okay, all right. And then, yes, so Sandra put it nicely, they reduce glomerular filtration. They reduce pressure, right? They reduce pressure of filtration. Okay, everybody okay with that? Yes, ACE is first, then ARBs. Okay, and then the last one, right, is I. Retinopathy. Retinopathy in the United States and actually the Western world, right? People going blind during middle age in their 40s and 50s and stuff like that. The most common cause is diabetes mellitus, right? So in the Western world, in middle-aged people, very common. So you've got to be careful about this. Remember, the patient that gets diagnosed with diabetes and has type 2 diabetes goes to the ophthalmologist right away. Right? So look, they may show, oh, so the follow-up here, I had a picture to show you guys. Here it is. Okay? So you could see all these, right? You see all these areas here, bleeding and stuff like that. And that's recent bleeding here, right? Bleeding here and stuff like that. And then, these white areas. This is old edema. And now, right, exudates and stuff like that. That's old bleeding there. Right? So this guy, you can see everywhere. He's got it everywhere. So when you see it everywhere, you think about diabetes, right, as the first possibility. Now they could tell you guys that this patient has neovascularization. What's that? So it has this picture plus neovascularization. So new vessels. So what's the problem now? Right, it's called proliferative retinopathy. Proliferative. So what's the story with proliferative retinopathy? That could lead and they go blind. Right? So what do they expect you guys to do if they tell you about proliferative retinopathy or neovascularization? They expect you to know that you have to do laser photocoagulation. Okay? Everybody understand that? That's why you send them to the eye doctor to follow up. And if they see this proliferative retinopathy, they do photocoagulation. Okay, very good. So along those lines, right, they may ask us about follow-up in the microvascular stuff, right, especially the eye. So type 2, you do a yearly eye exam by the ophthalmologist, right? And remember, you send them to the ophthalmologist right away. As soon as you diagnose them, right away, from the get-go. Type 1, do an eye exam in 5 years, and then yearly. Why? Because it takes 5 years for type 1 to develop the microvascular complications. Okay, watch this. The foot exam is yearly. Okay, yearly for type 2, and usually we send to the podiatrist. Podiatrist, very important. Okay, everybody okay with that? You don't have to do Dopplers. You have to do the microfilament test, right? And the podiatrist has to see the feet to clip the nails. Okay? Everybody okay with that? Okay, very good. So we talked about the diabetic retinopathy. Let me finish up talking a little bit about the medications. So I want to write the medication here. So look at here. When you talk about type 1 diabetes versus type 2, right? Type 1 diabetes only gets one thing. There's only one thing. They can only get insulin. That's it. All right? So insulin for type 1. Okay? Nothing else except plus lifestyle modifications. What's lifestyle modifications? What do I mean by lifestyle modifications? Exercise, right? Dietary, loss of weight and stuff like that. Watch your weight. These patients are usually skinny anyway, right? But that's what I mean. Type 2 is a whole different entity, right? These patients, you could have lifestyle only, and then if this doesn't work, you can add oral, and you could try one of 3 groups of oral treatment. So right now, data is only good for 3. So you guys don't have to remember a lot of medications here, right? And then if this doesn't work, right, then you add on insulin, right? So a patient with type 2 diabetes could be on 3-4 medications, right, including insulin, lifestyle modifications, or it could be only on lifestyle, or only on lifestyle and 1 medication, or lifestyle and 2 medications. There's different combinations here, right? So bottom line, if all fails, then you give the patient insulin. Just be thoughtful that when a patient has type 2 diabetes for over 10-15 years, they tend to act more like type 1 diabetes, and they need insulin and stuff like that. Okay? Everybody okay with that? All right, so what's the role of oral hypoglycemic agents in type 1 diabetes? What's the role of oral hypoglycemic agents in type 1? The answer is none. There is no role. For our purpose, it's none. Okay? Everybody okay with that? For our purpose, it is none. We only use oral hypoglycemic agents in type 2. All right, so if I catch somebody with type 2 diabetes early, what do I start with? Lifestyle. And if that doesn't work and I need something more, yeah, I'll give him metformin, right? And if that doesn't work, I add something more, like sulfonylureas. See, I rather use oral before insulin, right? And Niraj says, if that doesn't work, then I give him a TZD. What's a TZD? Give me an example of TZD. Pioglitazone. There you go. That's the only one you got now, pioglitazone. All right. Rosiglitazone is off the market, right, a couple years ago, because it caused increased cardiovascular events, even though it was a good drug. Okay, look at this. We're going to talk about these 3 medications. For your purpose, for step 2 and step 3, there's nothing else you could use. So this GLP peptide inhibitors, we don't have enough information yet. There are not enough randomized controlled trials. See, that's great, because you guys don't have to know it. See, in step 1, they ask you about mechanism of action, right? But in step 2, they can't ask you to use it, right? All these newer drugs that have come about last 40 years, you guys can't use. If you're going to take the test within the next couple of years, don't have to worry about anything. Nothing's coming out there to prove 100% that these could be used. Okay? And then if all that stuff doesn't work, then what is my default here? Then I add on insulin. Okay? I add on insulin. Everybody okay with that? All right, so let me talk about the oral hypoglycemic agents. So number one is metformin. Number one is metformin because you use it before anything else. Nothing is as good as metformin. All right, so that is numero uno. Okay, that's right. So Doug said it doesn't cause hypoglycemia. Sandra said it reduces morbidity and mortality. It does. See, that's the one that had the highest reduction in morbidity and mortality. Okay? How does it work? You don't get weight gain with metformin. That's why it's so good. It may cause GI side effects. Yes, that's the answer. So it works through inhibiting neoglycogenesis in the liver. Okay? That's one. Number two, does it increase weight? No, that's a big deal because if you increase weight, then you got more diabetes. All right, number three, does it cause hypoglycemia? No, it doesn't affect insulin and beta cells, so you don't get hypoglycemia. Now, Doug said it reduces weight, it's got weight loss. That's unclear, but it doesn't increase it, right? Which is it's as good as anything. That's less clear. You know, the companies say it does reduce it and stuff like that, but the studies haven't been, eye-opening. Okay? All right, so look at here. Don't answer first. Let me finish and then you guys could answer. What is the most common side effect of metformin? All right, so the answer is GI. Okay, nausea, a little bit diarrhea and stuff like that. That's the answer. Look, if it was lactic acidosis, this wouldn't be a number one drug, right? So it's usually GI disturbance, and that's why people, when they use metformin, they start low and they work their way up. Okay, everybody okay with that? All right, very good. All right, so now what's the worst side effect? What's the most feared side effect? All right, Sandra said it. So it's lactic acidosis, right? All right, so look at this. When do we see lactic acidosis? All the stuff I just covered has been asked over and over again about metformin. It's been seen with renal failure. Everybody remember that? All right, so where is metformin contraindicated? Renal failure, and you definitely don't want to give contrast to them. All right, there you go. Why don't we give metformin in renal failure? Because they may get lactic acidosis, and that's bad news. Okay? You remember we said it yesterday. I said it quickly because I was answering a question. One of the things that the radiologists dread is giving contrast dye to diabetics who are taking metformin, because they say, look, if I give contrast dye and I put this guy in failure and he's taking metformin, they could get lactic acidosis, right? So what some radiologists do, it's not widespread, but some radiologists say, look, stop this guy's metformin, right? Stop this guy's metformin today when I'm doing the test and maybe for a couple of days later. That's what they usually ask for. Okay? Everybody understand that? Metformin is number one. Okay? Side effects are mild. They're mild GI side effects. Okay? Very good. Number two is sulfonylureas. All right, give me an example of a sulfonylurea. Give me a name, or glyburide, glipizide, right? Stuff like that. All those are sulfonylureas, right? Some of the older ones, tolbutamide, they're still used in other parts of the world. Okay, now look at this. how do they act? Remember we said metformin inhibits new glycogenesis. Okay? So these work through releasing insulin from where? The beta cells. That's right. So they act on the beta cells to release insulin. Everybody okay with that? So right away, you guys should know two side effects. Two side effects right off the bat. One is weight gain. If you secrete insulin, weight gain. And what's the other one? If you secrete insulin, you get hypoglycemia. Okay? Those are the two side effects. How are most sulfonylureas removed from the body? Metabolized. Renally. That's the problem. Except for some exceptions like tolbutamide and one or two other ones. Right? I don't know. SIDH? I don't know, but I don't know where the SIDH came from. You guys may have a point. I don't know what is it in reference to? See, somebody said it, but I think that people just write. I'm not sure. So SIDH? Oh, from sulfonylureas? Oh yeah, you could get SIDH from sulfonylureas. Yes, you could get it. I see what you guys are saying. I understand. Okay, yes. Sulfonylureas have been associated with SIDH. Okay, as a side effect. Now I understand. Okay? Everybody okay with that? But the biggest side effects that I just told you about are what? Weight gain and hypoglycemia. Everybody okay with that? That's right. Yeah, there's a lot of other ones, but those are the basic ones. Okay, so we just said that almost all of them get secreted by the kidney, right? Or I should say, get metabolized by the kidney. So can I use them in renal failure? Most of the time is no. All right, so look at this now. Is renal failure common in diabetes? Of course it is. Right, so tolbutamide is, right. That's why, Sandra, I talk about tolbutamide. I mean, people don't use a lot of tolbutamide in this country, but you could use it in renal failure, right? And then there's one or two more. But in this country, the point that I was making is if you don't have a lot of tolbutamide around and some of the other ones, the older ones, what do you go straight to? You can't use metformin, you can't use sulfa drugs. Where do you go? You wind up, right, you wind up with insulin. That's the point I was making. So a lot of people here in this country, you'll see if they have renal failure, kidney injury, they go straight. Everybody okay with that? Okay, wonderful. And then number 3 are the TZDs, right? TZDs. So what did I say was the only one you could use right now? Pioglitazone. And that may be taken off the market over the next couple of years because people are reporting a lot of liver issues, right? Liver issues. Okay? How does pioglitazone work? How does pioglitazone? Yeah, Rainey said bladder cancer. Yes, it's been associated with bladder cancer. There you go. So it decreases insulin resistance or increases insulin sensitivity. There you go. See, so when you use these 3 drugs together, right, they're hitting a different point of the problem. Right? Metformin stops the neoglycogenesis. Sulfa drugs secrete insulin through beta cells. TZDs reduce insulin resistance. So you'll see many diabetics taking all 3 of these drugs. Okay? Everybody okay with that? Okay, remember these. Metformin, there's going to be a question about. All right, side effects, stuff like that. Definitely. Okay, very good. You guys know them well. Last thing here, I want to talk about insulin regimens. All right, so look at here. if I had the pie in the sky, right, I would use, right, a type of insulin that one would have a long-acting effect trying to simulate secretion by the pancreas. The pancreas secretes small amounts of insulin, right, just to have a basal state of insulin on board. So if I give this guy with the arrow, if I give him this long-acting insulin here, then here, right, that's the third day, right, I get basically, with this long-acting insulin, I simulate the pancreas very well in the basal secretion, right? So I get a small amount of secretion of insulin throughout the day, right? So what type of insulin am I talking about? Where it's long-acting and you can give it once a day. Good. So Levemir, right? Glargine, glargine, right? Very good. Okay, so glargine insulin. So I'll put glargine, Levemir, right? Works very well for me. Okay, glargine. Okay, everybody okay with that? Long acting. All right. So now, all right, so that covers that basal state, right? Well, what happens, what do I do when the patient eats meals? Okay, I give him a shot of ultra short acting. That's breakfast, right? Ultra short acting. That's lunch, that's dinner. See that? Right? So give me an example of ultra short acting. Good. Lispro. How about another one? Aspart. Very good. Aspart. Wonderful. So I give the long-acting insulin to cover that kind of 24 hours, right? Kind of low-grade secretion. And then with the meals, right, I give them a shot of ultra short acting. Ultra short acting acts like in 10 minutes, right? Then it goes away. See, boom, goes up and down. Okay? So the day looks like this. 3 shots, right? And the long acting one. So this is the best way you could control diabetes. But what do you guys notice right away? It's easy to say, but how many shots does this guy have to do a day? Or this woman? 4, right? 4 shots. And what else? How do you know how much to take of ultra short acting? How do they figure that out? Good. My method says a sliding scale, but how do you get that sliding scale? So now you got to check, right, your sugar, right? So one or two possibilities to figure that out. Either to calculate your carbohydrate intake, right? That's not as specific, right? Or to do an AccuCheck every time after a meal and say, okay, my AccuCheck is 200, right? I need to take 7 units of Lispro. Or my AccuCheck is 250 and I have to take 10 units, kind of like that. So what do you need to do this pie in the sky? You need a very motivated patient, right, who knows what they're doing and knows that they need to follow up, right? Oh yeah, people, I have diabetic patients that are maniacs about control. They do this and they check their sugars all the time. They're amazing. But look, what's the point I'm making though? You have to have a patient like that. Can't be a guy that doesn't follow up, right? They're not going to do this. They're not going to give themselves 4 shots a day and check their sugars 3 times a day. But this is what you need. This is how you control diabetes. This is why with this type of control, patients now are getting less kidney problems and eye problems and stuff like that. Okay? Everybody okay with that? So a combination of long-acting and ultra short-acting insulin. That's the way to go. See, the old insulin, right? The NPH and the regular, they used to look like this, right? They used to look like this. See that? Right? And then you used to give another shot, right, in the afternoon and like this, right? So what do you notice? You get all these peaks and valleys. So you got too much and too little at time, right? So this is why, yeah, you get too high and too little. This, the glargine insulin, right? It's stable. It doesn't give you a peak, right? It just, yep, that's the ideal. Okay? Right. With these ultra short acting and long actings, you get less hypoglycemia, right? It's the older ones, the regular, right? This stuff here that you get more hypoglycemia with. Okay? Everybody okay with that? All right, let me do one more thing and then we'll take a break. Okay? Oh, let me go back to right here and then we'll finish up and then. Okay, so because of the way that we manage diabetic patients now, right, with the type of new insulins, this Samoji phenomenon, which used to be rebound hyperglycemia, we don't see anymore. The dawn effect, we don't see anymore. So I put them here just to remind people, right, so they're not tested. So this is kind of like historical stuff, right? We don't see it. All right, so but this we may see. Okay, the honeymoon period. So what's the honeymoon period? What's that? So type 1 diabetic, I sent home, then she calls me up, a week later and says, you told me I have diabetes, but my sugar is now normal. Good. So Maggie says symptom-free period after decay, right? So they have a residual B cell mass, right? So they still have residual B cell function. That's what that is. All right, why am I telling you this? How do you treat the honeymoon period? So this woman was telling me, I'm getting hypoglycemic. I have to stop my insulin, right? So what do I tell her? Do I tell her, okay, wait till you get DKA again, and then, come and see me? What do I do? Monitor. Adjust the insulin. That's what it is. All right? So you adjust the insulin. What do I do to the insulin? I cut it down, by a lot. I cut it down, but this patient still needs small amounts of insulin. They're going to get DKA and come to your office a couple of months later. Okay? So honeymoon period is residual beta cell mass. What do? I don't stop the insulin. I lower the insulin. And I tell her to monitor her sugar closely because her needs are going to go up as time goes by. Okay? Everybody okay with that? Right. This is type 1. Doesn't happen type 2. So this is type 1. Okay? Everybody okay with that? All right. Last thing, and then we'll take a break. So when we talk about hypoglycemia, right? We talked about hyperglycemia and diabetes and all that stuff. I want to say a few words about hypoglycemia. So the definition is not only a low sugar, right? It's not only a low sugar. What are the other things you have to have in order to have the syndrome of hypoglycemia? We don't use regular insulin and NPH anymore, right? So you try to keep away from that. All right, so what's the definition of hypoglycemia? So you got a low sugar, you have symptoms, right? And what's number 3? You got low sugar, consistent symptoms, and then the symptoms go away with what? With food, with glucose. That's it. That's the triad. Low sugar, symptoms go away with food. All right, so good. There's 3 possibilities that you could have. 3 possibilities. If we know these possibilities, we're done. we don't have to worry about anything. So here it is. So you have low glucose, and in one case you have low insulin and low C-peptide. That's one case. In the second case, you have low insulin, high insulin. Sorry about that. This is high insulin. Okay, everybody see that? And high C-peptide. And then the third possibility is high insulin and low C-peptide. All right, so that's all they could give us, all right, for our purpose. All right, okay, so number one. What's number one? This patient doesn't have diabetes, right? This patient has hypoglycemia. They don't have diabetes. They come in with hypoglycemia. This is a low sugar. I'm not talking about diabetics now. All right? What does case number one have? Okay, so if I tell you guys this is a very attractive nurse, everybody picks. All right, I see some right answers. Right, everybody picks exogenous and stuff like that. So look at here. Look at here. So I think it was Mariana that got it correctly from the beginning. All right, so good for you. All right, so and I saw some other people too. So look at here. If your glucose is low, what's a normal response to low glucose? Your insulin shuts off, right? And if your insulin shuts off, your C-peptide goes down because it's co-secreted with insulin. So this is a normal response to what? To fasting. So this is the poor intern that you guys are giving so much work to. The poor thing doesn't have time to eat, right? And is running around the hospital like a chicken without a head. Okay? So this is an appropriate response to fasting. Okay, now look, people get this with these high protein diets, right? So, you know, low carb, high protein diets, that's what they get. They get hypoglycemia, right? And they get an appropriate response to that, which is low insulin and low C-peptide. Okay, so this person's fasting. Tell them to eat more. Tell them to take a couple of chocolate bars with them, you know, eat in between meals, etc., etc. Okay? Everybody okay with patient number one? That's easy, right? Okay, how about patient number two? All right, so people said insulinoma. Insulinoma is correct, but it wasn't a possible answer. Okay, so if it's not a possible answer, we got to have a number two. All right, so Tyler said sulfonylureas. That's the right answer. So what if people are taking exogenous sulfonylureas? They're not telling you. You know, they're messing with you. If the sulfonylurea, right, would activate the beta cells to secrete endogenous insulin, right? That's why the C-peptide is elevated. Okay? Everybody understand that? Sulfonylureas or insulinoma. They can't give you both. They got to give you one or the other. If they give you this, it's likely going to be sulfonylurea. Okay? Everybody okay with that? And then number 3 is what? This is exogenous. Okay, so factitious, exogenous, call it what you like. Okay? All right, anybody know these people that take insulin? What's their typical? What are they? I don't take insulin for diet. Mm-mm. Nurses, medical personnel, doctors, medical students, or people that have diabetics in their family. So this is called, right, this is called a factitious disorder, right? And not malingering. What's malingering? This is a good question for you guys. What's malingering? What's the difference between a factitious and disorder malingering? This is Munchausen syndrome. Yeah, so malingering is there's a definite profit. Like, okay, I told everybody at work I got back pain, so I could sit and, I could stay home and, go fishing for a couple of days. That's malingering when there's a specific gain. Right here, the gain is, that it's not specific. They're trying to attract attention to themselves, but there's no gain that makes sense. Okay? Everybody okay with that? All right. I'll stop there. We'll take a 10-minute break and we'll come back and finish this up. All right, everybody, we're almost done. Did that sound okay? All right, so we want to finish talking about the adrenals. We'll leave a little bit for next Saturday to finish up this Saturday coming up, just a little bit, probably about half an hour. I don't want to rush. I want to make sure that everybody understands these concepts. You know, endocrinology is a lot about concepts. When we talk Saturday about GI, you'll see that that's a little bit more straightforward. Okay, so I want to speak to you and make you understand how to work up patients with Cushing's syndrome. So we know that the classic presentation of Cushing's syndrome includes acne, buffalo hump, moon faces, striae, especially purple striae, truncal obesity. These patients also get hyperglycemia. Now you guys should know by now, because we've talked about it a couple of times, why they get hyperglycemia. They get oversecretion of cortisol, which is a counter-regulatory hormone. It counter-regulates the effects of insulin. So these patients, just like acromegalic patients, develop hyperglycemia and sometimes frank diabetes. And this is the same concept where we put patients on cortisol derivatives, and then they may develop diabetes again, right? So 20-25% of them get frank diabetes, right? They get steroid-related diabetes. Most people believe that maybe these people are predisposed. They also may develop hypertension because cortisol derivatives, when secreted in large amounts and over a long period of time, they have mineralocorticoid effects. And this causes hypertension. So hyperglycemia, hypertension, and then you'll know about the osteoporosis related to cortisol. So, but the interesting thing is that this type of Cushing's presentation really only occurs, the typical one occurs when it's iatrogenic. So these patients are taking corticosteroids for, let's say, steroid-dependent asthma or lupus or something like that. They're taking it for a long time. And then the other possibility is when you have a pituitary adenoma. A pituitary adenoma secreting ACTH, activating the adrenals to secrete what? Cortisol. Right? What is that called? That is called Cushing's disease. So the typical Cushing's syndrome occurs in Cushing's disease. Cushing's disease is also the most common form of Cushing's syndrome if you take away iatrogenic disease again. Iatrogenic disease, we usually know about it. It's not a diagnostic dilemma. So Cushing's disease is the typical Cushing's. It's the benign type of Cushing's syndrome that we see, and it is the most frequent one. When I say benign, what do I mean? People have this disease 10 years before anybody picks it up. So we got to know those details about Cushing's disease. What's Cushing's disease? It's the type of Cushing's syndrome where you have a pituitary adenoma. The syndrome is everything together, all the diseases together, right? The disease, right, is when you have the pituitary adenoma. Cushing's disease is the pituitary adenoma. That was the original case that Harvey Cushing at Hopkins over 100 years ago diagnosed a patient with a pituitary adenoma. Okay, everybody okay with that? Now that's the most common one. Yeah, it's the symptoms are collective, right? So Cushing's syndrome, right, is all the causes, right? Everything collectively. right? Iatrogenic, exogenous, right? So everything together, we kind of put it under Cushing syndrome. But what I'm telling you is, if it's not iatrogenic or exogenous that we usually tend to know about stuff like that, then it's really about one of three diseases. It's either Cushing's disease, that's in the pituitary, or going down a little bit into the lung, it's lung cancer, right? So think about that. How does lung cancer cause Cushing's syndrome? So it's a paraneoplastic syndrome, right? There you go. Paraneoplastic syndrome. Very good. ACTH. Very good. And then, lastly, it's something in the adrenals. Not adrenal dysfunction? Not adrenal dysfunction, right? So you secrete either ACTH and you produce more cortisol. Adrenal neoplasia or adrenal hyperplasia causes production of cortisol, right? Everybody understand that? So these two diseases here, ACTH is elevated. Watch the words you guys use. Dysfunction and stuff like that means something different, right? This case here has low ACTH, right? That's the big difference between these two. Everybody understand that? So what are the three diseases that we traditionally think about when we talk about Cushing's syndrome? Pituitary, that's called Cushing's disease. That's the most benign and the most common one. Then it's lung cancer, right? This adrenal neoplasia or hyperplasia produces cortisol, right? Produces cortisol. And it has a negative feedback back here. Everybody okay with that? Okay. So all of them have cortisol secretion, right? Everybody feel comfortable about these? What did I say is the most benign one? Cushing's disease. Okay. Which ones have elevated ACTH? Cushing's disease and lung cancer. Which one has low ACTH? Adrenal neoplasia or hyperplasia. There you go. What if I say, who's got hyperpigmentation? Who in Cushing's syndrome has hyperpigmentation? Good. Disease and lung cancer. There you go. In Cushing's disease, you produce ACTH from the pituitary. In lung cancer, you produce ACTH from the tumor, the small cell cancer. In adrenal neoplasia or adrenal hyperplasia, you produce cortisol from the adrenals, right? That has the negative feedback to ACTH. Okay? Everybody okay with that? All right. So let's work this patient. Oh, let's work this patient up and let me show you how to diagnose Cushing's. Huh? What happened now? Huh? What was that? Hmm. Maybe Brad or Maggie could tell us. I don't know. Nice song, right? Tech Art. All right. It's okay. Right. Wanted to wake you guys up. Notice some of you guys were dozing off or watching some TV at the same time or something. All right. So look at here now. I'm thinking about Cushing's, right? All right. What do I do? I do the first thing that I do is this thing called the overnight dexamethasone suppression test. What's dexamethasone? What is dexamethasone? Cortisol. That's all it is. It's a cortisol derivative, right? So look at here. If I measure cortisol in the morning and the cortisol is suppressed, right? It's a more potent cortisol derivative. So I measure cortisol in the morning and it's suppressed. This patient is normal. I was able to suppress it. So what does that mean? This patient doesn't have Cushing's. Everybody understand that? They don't have Cushing's because I was able to suppress it. If the patient has autonomous secretion of cortisol, I wouldn't be able to suppress it. So I just excluded it. So here, no Cushing's, I'm done. I don't have to do anything more. It's basically to rule out Cushing's. But look at here. What if my cortisol level is elevated? So now I think maybe I do have Cushing's, right? But could anything else cause an exaggerated cortisol level or a non-suppressible cortisol level? Yeah, so morbid obesity could do it. Stress could do it, right? So other false positive things, psychosis, alcoholism, all that stuff. So you think about Cushing's, of course, right, versus something else, versus stress, versus, morbid obesity, something different. Okay? Everybody okay with that? Yeah, false positive, right? You don't know. So now you have to do the gold standard, right? You got to do the gold standard, right? The gold standard is the 24-hour free cortisol. Well, 24-hour free cortisol. Okay, this is the gold standard. This is the gold standard. Now look, I gave you the dexamethasone first because a lot of people do that first. But if they give you both of these, you could do the 24-hour free cortisol because this is the gold standard. Okay? So you don't follow the 24-hour free cortisol with the dexamethasone. Here's what you could do. You either use the overnight dexamethasone to rule out Cushing's and stop there, or you could start with the 24-hour free cortisol. You could do that, but that's going to mean that you're going to do a more expensive test, a more complicated test. Right, so basically you start with the dexamethasone. People like this because you say, okay, I'm going to do a very simple test and I may be able to rule it out. Right? So it's a very sensitive test, right? But it's not specific. So if the dexamethasone you're unable to rule it out, then you have to do the 24-hour free cortisol. Okay, the 24-hour free cortisol is you measure urine for 24 hours and you send it away and they measure free cortisol levels. Okay? Everybody okay with that? So hold on. So I said you could start with the dexamethasone, right? Some people prefer to start with the 24-hour free cortisol. If you do, then you don't have to do the dexamethasone, but it's a more complicated test. If they give you both of these tests, let me just make it simple for you. They give you both of these tests and they tell you what is the best test, which one of these is best to diagnose Cushing's, then you're going to do the 24-hour free cortisol because that is the gold standard test. Everybody understand that? The dexamethasone is kind of like a screening test. We don't use the word screening because you're not really screening, but it's kind of like a rule-out test. Okay, the 24-hour free cortisol is the real deal. Okay, everybody understand that? So both of these can happen. They shouldn't ask you both of these, but I just gave you the answer. If they do ask you both of these, then it's the 24-hour free cortisol. Whatever this says, it's true. If this is normal, the patient is normal. I'm talking about the low dose dexamethasone. Just follow me here. Okay? Just follow me. I'm talking about the low dose dexamethasone. That doesn't tell you where the lesion is. It tells you if you got Cushing's or not. Okay? Everybody understand that? I'll get to that. So whatever the 24-hour free cortisol tells you, that's what it is. If it's elevated, this patient has Cushing's, no doubt about it. For our purpose, there's no doubt. Okay, everybody understand that? So basically, how many tests? How many tests did we do? I told you, this is called the overnight dexamethasone suppression test. Only 2. And they may give you only 1, right? Because if with the dexamethasone suppression test, you rule it out, it's only 1, right? Or if you elect to go straight to the 24-hour free cortisol, it's only 1 test. Everybody understand that? So everybody gets like Cushing syndrome, all like, complicated and stuff like that. But the bottom line is that you only have 2 tests to say, does this patient have Cushing's or not? Okay? Everybody okay with that? The dexamethasone is called the overnight dexamethasone or low dose dexamethasone. Okay? So I'm right here now, right? I've diagnosed Cushing's. All right? Everybody okay so far? So now I'm going to, figure this out and present it at morning report and be a hero. Right? So now you guys got Cushing's. All right, so let's go here. Positive Cushing's. Because my 24-hour free cortisol said so. Okay, so what do I do now? So now I do my high dose. What's the high dose? I increase the dose of dexamethasone. Why do I increase the dose of dexamethasone? Because the dose of dexamethasone, this is about 8 milligrams. The low one is about 1 milligram, right? So high dose dexamethasone will suppress the benign lesion. Will suppress the benign lesion. Right? So if I do the dexamethasone and I measure it, the cortisol, and it's suppressed cortisol, where's the lesion? In the pituitary, right? So what do I do next here? It's a pituitary tumor, right? How do I image the pituitary? All right, so I do an MRI of the pituitary. There you go. Everybody okay with that? MRI of the pituitary, right? And I confirm it, and I send them to the surgeon, and I got a happy camper. Okay? Now sometimes if they do the MRI, the lesion may be so small you can't find it. You can't see it on the MRI. So what they do sometimes is this thing you may hear. They won't ask you in step 2. They do what is called petrosal testing. So they go from one side to the pituitary to get some blood, and then to the other to see where the lesion is. Try to localize the lesion. Okay? But we're good to go with the high-dose dexamethasone suppression test. That's suppressed here. See, I suppressed cortisol, so I know it's in the pituitary because it only suppresses the benign one. I get an MRI, I find it, right, etc., etc. So what happens if my high-dose dexamethasone, I'm unable to suppress cortisol? So now what do I have? Either lung cancer, right, lung CA versus adrenals, right? So it's either lung CA or adrenal hyperplasia, something like that, okay? All right, so what do I do now? All right, so now, look at this. Now I get my ACTH level, right? If my ACTH is elevated, it's in the lungs. Lung CA, get a CAT scan of the chest or something like that, right? If it's low, it's in the adrenals. Adrenals, right? Get something that you could image the adrenals. See, we always leave imaging for last in endocrinology. Okay? Everybody okay with that? CT, right, or MRI or something like that. One of those. It's probably going to be a CAT scan. Okay? I do to localize the lesion. How many tests did I do? High dose, right? High dose dexamethasone, right? And ACTH. And then I do my imaging. Okay? So either 1 or 2 before the imaging. Before the imaging. Okay? Everybody okay with that? So how many tests did I do to diagnose the disease? 1 or 2. How many tests did I do to localize the disease? 1 or 2. What's my test to diagnose the disease? What are the 2 tests I use to diagnose the disease? Overnight dexamethasone and diagnose the disease and 24-hour free cortisol. And what are the 2 tests to localize the disease? Find out where it is. High-dose dexamethasone and ACTH. Okay, watch the high-dose dexamethasone. The premise of the high-dose dexamethasone is if I give a higher dose of the dexamethasone, I suppress the benign lesion, which is in the pituitary. The lung cancer and the adrenal are more aggressive forms. They don't suppress. See here? No suppression. Okay? Everybody okay with that? They can't give us, take me from here to there. They give you, this guy had an elevated 24-hour free cortisol, plus his high-dose dexamethasone was suppressed. Where's the likely lesion? Or where do I do imaging? What type of imaging do I do? Right, so you say, okay, that's the pituitary. Let me do an MRI of the pituitary. Okay? Everybody okay with that? All right, you guys feel comfortable, right? So don't make it more harder than it is, right? 2 tests, done. Know what they they know what they mean, and you're okay. Okay, very good. So we'll go over that on Saturday really quick. Make sure if I could ask you guys to just take a look at this tonight, just briefly. Okay? No, they're going to ask these questions. There's going to be one question on Cushing syndrome. There's not going to be harder than that. I assure you. Okay? All right. Last thing, and we'll finish up with this. I want to talk about not harder than this. No. Listen, Sophia, if we don't know it, it sounds like a mountain to us. But this is about the hardness the level of difficulty that it is. Okay? Okay. So a little bit about, I want to finish talking about hyperaldosteronism, right? Oh, and I want to tell you guys about two different diseases and finish up talking about these two important diseases. So look at here. So do you guys remember why aldosterone is very important? Remember, this is your main mineralocorticoid, right? So what does it do? Without aldosterone, right, you can't reabsorb salt, right? You can't maintain volume. Little kids that are missing aldosterone, they have salt wasting nephropathy. They get in trouble. You can't balance your volume, right? And remember, what's the other hormone? So you got to be able to hold on to free water. That's ADH. And you got to be able to hold on to salt. That's aldosterone. So aldosterone, right, is the other balance to ADH, right, to stabilize volume. So it increases intravascular volume because it reabsorbs sodium, right? And by reabsorbing sodium, well, you lose something. You lose potassium, and you lose hydrogen ions. So what does this do? You lose hydrogen ions and you get metabolic alkalosis, right? So this is important, this concept here, where aldosterone, right, reabsorbs sodium, increases intravascular volume, right, but in the meantime, wastes potassium and hydrogen ions, causing metabolic alkalosis. Okay? All right, very good. So, what diseases do we have? Well, let's go on the whiteboard and figure them out. So, the first one is something you guys will see almost every day in clinical practice. So, look at here. It starts from here. So, we're talking about aldosterone, right? So, decrease in intravascular volume occurs because this patient gets dehydrated. I don't know, he gets over-diuresed, right? I don't know, he starts vomiting, something like that. So look at here. This activates renin. Renin activates aldosterone. Here's aldosterone, right? And this reabsorbs sodium and it tries to stabilize the decrease in intravascular volume. All right, so some of you answered this. They said, wait a second, this is great. This is called secondary aldosteronism. This is what this is called, secondary aldosteronism. Secondary to what? To depleted intravascular volume that secretes renin, right? So that's why it's also called secondary dehydration, right? Something that dehydrates the patient. And it's also called renin dependent. Renin dependent because it's dependent on the renin secretion. The renin secretion is really what? It's dependent on the intravascular volume. The intravascular volume is what activates the renin here. Everybody see that? To secrete excess aldosterone. Right? So every time you guys dehydrate a patient in the hospital, or a patient gets dehydrated, or we over-diurese them, and all that stuff, this is what we get. If I wanted to measure hormones and confirm that this patient had secondary aldosteronism or renin-dependent aldosteronism, I would measure aldosterone and renin at the same time, and what would I find? That they were both elevated at the same time. So secondary aldosteronism, because it's renin-dependent, you have an increase of renin and aldosterone at the same time. Everybody okay with that? All right, good. So last thing here, two things. All right, so what do we have though? We're reabsorbing sodium. What are other things that happen? Well, you lose potassium, so you develop hypokalemia, and you get metabolic alkalosis, right? Everybody okay with that? So they may ask you a question about somebody you are treating for heart failure, and you're treating them with furosemide, right? A loop diuretic, and you're giving him furosemide, and this guy develops hypokalemia and metabolic alkalosis. All right, so what do you need to do? What are they telling you? You got hypokalemia and metabolic alkalosis. So what's causing the hypokalemia and metabolic alkalosis? Well, the loop diuretic is wasting potassium too, but the point that I'm trying to make is, what are you doing? If you're causing metabolic alkalosis on this guy, you're dehydrating this guy, right? You're causing secondary aldosteronism because you're over-diuresing this guy. Okay? Good. So Sandra says, you're over-diuresing this guy, so the answer in this case would be reduce the amount of the diuretic. You're giving him 60 milligrams of furosemide. Why don't you cut it down to 20 or something like that? Okay? Everybody understand that? All right. One more concept here. Patients with nephrotic syndrome or liver disease, okay? So if we give patients that have nephrotic syndrome or liver disease, overall, they have an edematous state. What does that mean? So they have low albumin, for example, right? They have decreased capillary oncotic pressure, so they third space. So they have too much water, but it's in third spacing, right? Everybody understand that? So people that have nephrotic syndrome or liver disease, their intravascular volume is what? Low. Their intravascular volume is low. So this system here, what happens to the system? This system is all revved up, right? Because their intravascular volume is low, they gear up the renin and the aldosterone trying to minimize this intravascular volume. So the edematous states, like liver disease, like nephrotic syndrome, and even heart failure, have this vicious cycle where your body thinks the intravascular volume is depleted. It really is depleted, and then revs up the renin and the aldosterone. And some people think it's the aldosterone that causes harm to a lot of these patients. But what is this? This is a mechanism by which your body tries to maintain normal intravascular volume. Okay? Everybody, it's a compensatory process. Very good. Okay? Everybody okay with that? Okay. So look at here. So this is secondary renin dependent. My renin is elevated, my aldosterone is elevated, my intravascular volume is depleted, so my blood pressure is probably low or something like that, and maybe some of these patients have edema. Okay? Everybody okay with that? All right, good. So how about this case though? This case, So the problem is down here, where you have uncontrolled production of aldosterone. This reabsorbs sodium, and if you reabsorb a lot of sodium, your intravascular volume goes up. And what does that do? Well, your intravascular volume goes up. What happens? I measure your blood pressure and you develop hypertension. Especially your diastolic pressure is very elevated. Okay, so now your body says, okay, my intravascular volume is elevated. Let me suppress my renin. Okay, because I don't need renin and I don't need aldosterone, right? And your renin says, okay, no more aldosterone, but remember, this is, there's something wrong with this. It has unopposed, it has, right, dysregulated aldosterone production. Everybody see that? So first of all, what is this called? This is called primary aldosteronism. Primary. Or what's another name for it? Conn's disease. Conn's disease. There you go. All right, so they also call it what? Renin independent, right? Look at here. Renin independent aldosteronism, right? So this is important to remember because they asked how to diagnose Conn's disease. How do we diagnose Conn's disease? I measure renin and aldosterone. Aldosterone is elevated, renin is low. I don't only measure renin, I measure aldosterone and renin. So aldosterone is high, right? Independent of renin. Renin is low. Okay? They may say, what's the aldosterone to renin ratio? It's high. If your aldosterone is high and your renin is low, your aldosterone to renin ratio is elevated. Okay? Everybody okay with that? All right, so this is called primary aldosteronism or renin-dependent aldosteronism. What do these patients have? They have hypertension. All right, so let me ask you guys this. Okay, it's kind of late, but it's good to remember. They don't develop pedal edema. They have no edema. Remember, I said no edema. No edema. Okay? So look at here. They develop hypertension. But what did they come to the doctor for? Remember hypertension? Hypertension has no symptoms. Guys, hold on. These patients here have no edema. Everybody understand that? They have no edema. They don't have what do they come to the doctor for? They don't come for hypertension. They don't have any symptoms from hypertension. There's no symptoms. They come in because the hypokalemia. They come in with proximal muscle weakness. That's what they come in with, muscle cramps and proximal muscle weakness. Everybody see that? Okay? Everybody okay with that? That's what they come into the doctor. So when they ask us on the USMLE, what's the most common complaint of hypertension? The answer is none of the above. They have no symptoms unless they get a hypertensive emergency. Then they have strokes and stuff like that. But 99% of the time, hypertension is asymptomatic. No headache, no nothing. So these patients have no symptoms. They come in because of hypokalemia. Okay? Everybody understand that? So what is this called? Conn's disease. Primary aldosteronism. How do I confirm the diagnosis, I check aldosterone and renin levels at the same time. What do I find? Epistaxis is not the first sign. Epistaxis, what did I say was hypertension? It's 100% asymptomatic. No symptoms. None. They've done randomized controlled trials. It is an asymptomatic disease. Everybody okay with that? They feel weak and lousy in this case, right? Because why? Because of a low potassium. Okay? Everybody remember that? Good. So how do I confirm my diagnosis? I check aldosterone. It's elevated. Renin is low. Okay? Everybody okay with that? Okay, very good. So you guys got to know both of these. So when we come back and I see you guys on Saturday, right? We'll do a quick 5-minute review of both of these. All right? All right. All right. You guys had enough of me now, huh? All right. Yep, I think it's noon. Okay? I'll see you all on Saturday. Have a good night, everybody. All right. And thanks, Mark and Amal and Brad, right? And Maggie. Okay? I'll see you all Saturday.